بسم الله الرحمن الرحیم. إنا أعطيناك الكوثر فصل لربك وانحر إن شانئك هو الأبتر إن شانئك هو الأبتر. بسم الله الرحمن الرحيم. إنا أعطيناك الكوثر فصل لربك وانحر إن شانئك هو الأبتر. فصل لربك وانحر فصل لربك وانحر إن شانئك هو الأبتر. صدق الله العلي العظيم.
Hello and welcome to everybody. The great professors that have accepted to attend this meeting, they are all mentors and friends to me. I am very thankful to all of you. So without taking your time any longer, we'll start with Dr. Depur's presentation, and it's about repositioning of anti-cancer drugs molecules. So, let me just tell you that Professor Depur is one of the top 100 scientists in the world and a great mentor to me too. And he is a great guy. I'm sure that everybody will enjoy his talk. And Dr. Mohammad Jafari, Dr. Mohammad Jafari, his colleague, is here to do the questions and answers. If there are any questions about Dr. Depur's presentation. Thank you very much, and please start.
Hello, colleagues. Before I start my speech, I would like to take this opportunity to express my special thanks to Professor Haddad for executing this invaluable webinar, as well as Arsen for its sponsorship. I am grateful to all the audiences for their precious time and attention. I'm gonna talk about repositioning of anti-cancer drugs, molecules, and recent advances. In today's presentation, we are going to take a short look at how far we have come in repositioning of anti-cancer drugs. We provide a brief presentation in two parts. What is drug repositioning, and furthermore, we introduce some promising drug repositioning candidate for anti-cancer therapy. Let's start and define drug repositioning. From a clinical point of view, it's defined as using non-drugs to treat new diseases. And we have a similar definition from a pharmacological point of view. Finding new targets for all non-drugs. Drug repositioning refers to the identification of new indications from existing drugs. We can also define drug repositioning using different terms, for example, drug repurposing, reprofiling, retasking, therapeutic switching. A well-known example of drug repositioning is the use of sildenafil Viagra in erectile dysfunction. Sildenafil was originally developed for the treatment of coronary artery disease by Pfizer in 1980s. The side effect of sildenafil marked induction of erection was serendipitously found during the phase 1 clinical trial for the patients with hypertension and angina pectoris. After sildenafil failed in phase 2 clinical trial for the treatment of angina, it was redirected to treatment of erectile dysfunctions. Importance of the current pandemic caused by COVID-19. Scientists have been trying to find a proper treatment for this new disease among the well-known drugs. Therapeutic alternatives are right to drug repositioning, and the importance of repositioning in COVID-19 is clearly undeniable. In such emergencies, we usually don't have enough time to start looking and discovering for a new drug. Instead, drug repositioning would not require that much time and therefore is profitable. Indomethacin, azithromycin, naproxen, and chloroquine, and all the new about available drugs are all based on drug repositioning. Cancer is drug repositioning allows research to avoid carrying out preclinical tests and phase 1 trials, thereby reducing the cost of the drug development process. It also helps to approve and launch a drug by spending less amount of money and time compared to bringing a new drug to the market. When repositioning a known drug, we already have access to its pharmacokinetics, pharmacodynamics, toxicity, complication, and much more information, which will again save us time and cost. Let's look at drug repositioning methods. 3 representative methods used for the selection of effective testing and drug repositioning in cancer therapy: activity-based, literature-based, and in silico drug repositioning. literature-based drug repositioning approach is used to identify in license non-cancer drugs with published evidence of anti-cancer activity using PubMed, Medline, and databases of clinical trials such as clinical trial Group. In silico bioinformatic tools and main databases have helped to find interactions between drugs and protein targets. Based on their pharmacology, cancer chemotherapy drugs are divided in two groups. The development of highly targeted small molecules, especially tyrosine kinase inhibitors, and monoclonal antibodies are currently the main methods for targeting human cancer therapy. Monoclonal antibodies and TNFs and repositioning could only work in the second group. Imatinib, for instance, has 7 clinical indications. For example, imatinib tyrosine kinase inhibitor has significantly improved the outcome of chronic myeloid leukemia since its first introduction in 2001. Of thalidomide. In 1957, this drug was initially used to treat morning sickness, but was found to cause malformations in newborns. In 1957, more than 10,000 children in 46 countries were born with birth defects of the limb, leading to thalidomide withdrawal from the market. In 2006, 50 years later, was successfully repositioned for use in anti-cancer therapy and was approved by the US FDA for multiple myeloma owing to its anti-angiogenic and anti-inflammatory effects. In 2008, this drug was also reapproved for use in patients with erythema nodosum leprosum. Aspirin is the most widely used non-steroidal anti-inflammatory drugs worldwide and function as a cyclooxygenases, COX-1 and COX-2 inhibitors to suppress the conversion of arachidonic acid to prostaglandins and thromboxane. In 1891, there was an effect that could not be explained at the time, and is related to the fact that from its very early use, aspirin was known to cause a bleeding disorder. In 1897, while used as an analgesic and an antipyretic agent, aspirin is the most widely used NSAID drug worldwide. In 1953, leading to suggestion by Craven, a medical student, that aspirin might be used for the prevention of thrombosis. COX-2 promotes inflammation, pain and fever, and the development of colorectal cancer is often promoted. Next example, in 1922, metformin and dimethylbiguanide was discovered. In 1957, first introduced as an oral hypoglycemic agent for type 2 diabetes in the UK and France. In 19 95 hypoglycemic agent in the US, metformin as antidiabetic drug, lower plasma glucose by suppressing hepatic glyconeogenesis, improving insulin sensitivity, and enhancing peripheral glucose uptake and utilization through activation of AMP-activated protein kinase. In 2014, in the past decade, metformin has exhibited anti-cancer activities. Beneficial effect of metformin or on incidence and or survival in various cancer, including liver, prostate cancer, colorectal cancer, endometrial cancer, and pancreatic cancer. With routine chemotherapy regimen, failure to sustain cancer stem cells and rest of cells eventually cease proliferation. Targeting cancer stem cells by metformin can deplete cancer stem cells and blood vessels, and metformin selectively inhibit the inflammatory signature in cancer stem cells. So, combined treatment of cancer stem cells with metformin was more successful in inhibiting relapse of cancer. Fungal drug, itraconazole, is another example for drug repositioning. In 1980s, this drug is known to inhibit the ergosterol biosynthesis pathway in fungi. Like other family of antifungal drugs, it is effective in a variety of systemic fungal infections. In 2007, anti-cancer activity of this drug was first reported due to its newly discovered anti-angiogenic activity. Digoxin is an important example for drug repositioning. In year 78, this drug was a cardiac glycoside isolated from foxglove by William Wittering and used to treatment heart failure and arrhythmia. Digoxin was known as a potent inhibitor of sodium-potassium ATPase pump in cell membrane, and this pump regulates sodium ion gradient across cell membrane to efflux intracellular calcium ions. After 2 centuries, in year 1980, a few cohort studies with breast cancer patients had shown that digoxin decreased the breast cancer recurrence and aggressiveness, and as a phytoestrogen could interfere with estrogen receptor signaling in cancer cells, thereby suppressing the growth of breast cancer. 2 decades later, however, conflicting results were reported. The population who were taking digitoxin and other cardiac glycoside had a higher incidence of cancer compared to the control population. The use of digoxin significantly increased the breast cancer incidence among women in Denmark. Among the digoxin users, there was the higher risk for developing estrogen receptor positive breast cancers than estrogen receptor negative breast cancer. In 2012, the researchers screened GHDL and identified that this drug as one of the most potent inhibitor of prostate cancer cell proliferation in 2014 large-scale cohort study with long-term follow-up demonstrated that men who had used digoxin for longer than 10 years showed 46% lower incidence of prostate cancer, suggesting a potential anti-prostate cancer activity of this drug. The history of cardiac peptide, AMP, is very interesting. AMP is stored as propeptide in cycloplasmic dense granule of cardiomyocytes and is released into the bloodstream upon atrial stretch resulting from elevated blood pressure, thus decreasing pressure overload and reducing cardiac hypertrophy. AMP is a hard peptide hormone that belongs to a family of cardiac-derived and vascular-derived hormone with crucial role in cardiovascular homeostasis, like regulation of blood volume and pressure, in addition to its role in cardiovascular homeostasis. In the last year, the new property ascribed to AMP of inhibiting tumor growth has made this peptide an attractive candidate for anti-cancer therapy. The last example of drug repositioning for cancer therapy is nelfinavir, an antiviral drug. This drug is competitive inhibitor of human immunodeficiency virus, HIV, aspartate protease, and is being used in combination with other antiretroviral drugs to treat patients with HIV infection. From early 2000s, researchers have found potential anti-cancer activity of this drug. This drug exhibited a broad spectrum anti-cancer activity in the inhibiting the growth of Kaposi sarcoma, multiple myeloma, NSCLC. A common side effect of this drug was insulin resistance. Such example clearly showed that most of non-cancer drugs have little or tolerable side effect in human. Repositioning of non-cancer drug for anti-cancer therapy will be an excellent strategy for future anti-cancer drug development. Currently, an estimated number of 4,000 of active pharmaceutical ingredients have been approved for human use in the world. Approved drugs keep accumulating over the year, on average 20 to 30 new molecule entrants. Each year have been approved by US FDA, further expanding the space for drug repositioning. The EMA in Europe and the NIH and FDA in the USA have already launched drug repositioning programs to identify new use for existing pipeline. Medication developed by the pharmaceutical industry. A major problem of conventional cancer chemotherapy drugs, mainly DNA damaging agent in notorious side effects that significantly reduce the quality of life of patients. Thanks for your attention.
It was a great talk, the Professor Dehpour's talk. Professor Dehpour's colleague, Ms. Dr. Mohammad Jafari, is here to take one or two questions, if there's any questions from the audience. So no question at this time. We can, if you have any, we can have the question at the discussion at the panel at the end of the webinar. So The next talk is from my supervisor, one of my supervisors and mentors. When I was in Princess Margaret Hospital, Dr. Rebecca Wong, who is very kind, and I'm very thankful to her that she accepted to be here. And she has been, as I said, a mentor and also a friend to me since the time that I was 2002, 2003, that I was in Princess Margaret Hospital. So welcome to Professor Wong. Rebecca, please go ahead. We don't have her video.
Good morning.
Hi, Rebecca.
Hi. You show my slides?
Yeah, we will. Just wave or say next slide, whatever you want.
Okay, all right. All right. Good afternoon, everyone. I wanted to give a great appreciation and thank you to the organizing committee for allowing me to present today. Thank you, Behmen, for the wonderful introduction. Certainly missed the time when you were with us. So my talk is Theranostics, Opportunities in Oncology and Practical Considerations. I'm a radiation oncologist, and I've only started working in this space for the last 7 to 10 years or so. So it's really from that perspective.
Rebecca, can I just make a point? There are a lot of nuclear medicine specialists in the audience, so I think this talk will be very interesting to them too. Thank you.
Thank you. Next slide. The next slide is my disclosures. Next slide. In the next 15 minutes, I want to share some of the lessons that I've learned with the hopes that we can spark interest in building cross-discipline collaboration to contribute to this exciting and rapidly growing field. What, why, lessons learned, and some thoughts for the future. Next slide. The term theranostics is perhaps self-explanatory. It's a coming together of therapy and diagnostics. The term was first coined by John Feuchhauser in 1998 to describe materials that has the ability to provide therapy and diagnostics. This is typically accomplished by use of a radiopharmaceutical finding its way to a cellular target through a linking molecule as depicted in this diagram. Next slide. Here's a bit of a time capsule for some key milestones and under the pace of change in theranostics. And I think this is instructive in terms of how theranostic come to being, how it's brought into clinical practice, and hopefully going forward, we can do it in a much faster pace. 70 years ago, on the right, is at the top is a popular article featuring the famous patient that was cured by thyroid radioactive iodine for thyroid cancer. It was approved by FDA for treatment 10 years later. The excitement of this field is because we are at a crossroads of science, understanding the multiple targets in cancer and what motivates it to grow and disseminate. And therefore the ability to target them, the technology that has matured to allow us to target them, and the ability to run trials that will bring them into clinical practice. The emerging evidence is coming from targeting somatostatin receptors in neuroendocrine tumors, carcinoid tumors, and more recently in PSMA and prostate cancer. And we'll take a few minutes just to take you through them. Next slide. In a news article from Healthcare Business published just last year, it is projected that the global nuclear medicine market will grow to over $12 billion by 2025, with theranostics, the dark blue bar, radiopharmaceuticals dominating the growth. Here's the story around neuroendocrine tumors and the somatostatin story. It started in 1985 when Eric Krenning was present, Krenning score, Eric Krenning, who was present at an endocrinology postdoctoral meeting, where the presence of somatostatin receptors on intestinal neuroendocrine tumors were demonstrated using autoradiograph to visualize them for the first time. Rapidly after that, investigators solved the challenge of radiolabeling the peptide, and in 1992, the first patient was treated with PRRT, peptide receptor radionuclide therapy, labeled with indium-111. Toxicity is perhaps always important a consideration, and this particular radiopharmaceutical is excreted in the kidneys, and understanding of being able to use amino acid infusions to limit the absorption through the kidneys became part of standard practice up to today. That was established in 1990. Understanding the radiation dose delivery to the tumor, to the normal structures, is a much more complex business compared with external beam radiotherapy that has since been, is now very well worked out and accurate to the millimeters. In nuclear medicine and theranostics, this is an evolving field with improving sophistication. The concept of individualized dosimetry became popularized in 2005 and continues to be refined and debated. Here, images are acquired the week after the treatment is delivered, and using the properties of the drug itself, we're able to see the activity absorbed in the normal tissues in the tumor and be able to quantify the dose with some degree of error to inform what dose has been absorbed. The time from approval, understanding all of this, to the approval of the first diagnostic, which was octreoscan, was not that long, and it happened in 1994. The time to approval for its therapeutic counterpart, lutetium-177 dotatate, it was only happened in 2018 in the US and 2019 in Canada. Where a single randomized trial performed by pharma was able to demonstrate previous progression-free survival, as demonstrated in the curve on the right, and overall survival is expected also to be impacted, although it's still immature. Next slide. The success of the neuroendocrine tumor brought into sharp attention the focus on other areas, and specifically in prostate cancer. Here, the journey started around 1996 with PSMA labeled, again with indium, directed at radiolabeled antibody. This as a diagnostic tool was marketed, but because of its suboptimal performance, it was not widely adopted. However, it did pave the way to PSMA using small molecule to label with much better distribution and diagnostic properties. And that was achieved in 2014. And to date, there are the number of trials that are mounting, and we'll take a quick look at it in a moment. And there are at least 2 large active randomized trials positioned to establish this modality's role in standard clinical practice. Next slide. Here are some of the studies that have really just come on the scene in the last few years and is motivating excitement. This pair of study, both phase 2 randomized, use PSMA PET scans to identify oligometastases, and identifying them and using metastases-directed therapy, including stereotactic radiotherapy. And here the authors are able to show improvement in progression-free survival that is really quite promising. Next slide. Similar to a neuroendocrine tumor, the first evidence of efficacy of therapeutic radiopharmaceutical came from retrospective studies. And here's the first study that sparked the excitement from Germany, showing a 40% response rate, PSMA reduction of more than 50%, following 1 cycle of PSMA lutetium-177 in castrate-resistant prostate cancer. Next slide. This is followed by prospective studies from Australia, a very active player in this field, confirming this type of observation. Next slide. followed by phase 2 randomized trials, and in this case, again from Australia, where it's compared against cabitaxel, showing significant differences in PSA response as well as progression-free survival. Next slide. And what I call going for gold. These large-scale randomized trials, phase 3 studies are on the way. Just Vision trial ongoing, and the PR21, as we refer to it in Canada, has just been launched in both settings in metastatic prostate cancer, where it's compared against best supportive care, and PR2 compared against docetaxel standard regimen in clinical practice. The way that they're designed is anticipated that will form the basis for bringing them into standard clinical practice. Next slide. How are these journeys generalized to other settings? Next slide. This audience will be familiar with the rapidly growing set of biomarkers that are guiding and with potential for guiding theranostics. It does not take a lot of imagination to appreciate the potential value of sexually targeting markers such as HER2, EGFR, but even less commonly known markers that are cross-disease site targeting cancer pathways, hypoxia, inflammation, with suggested radiopharmaceuticals to target them has been emerging. Next slide. Part of the beauty of using radiopharmaceutical capable of imaging tumors is the potential to understand and quantify heterogeneity. Biopsies have demonstrated that even the same tumor have very different characteristics across the patient, and imaging tools will fill that niche very nicely once validated. Next slide. The choice of radioisotope is one important component in theranostics. There are traditionally gamma cameras using gamma emitters has been used. However, the ability to incorporate positron emitters using PET scans, positron emitting tomography cameras, provide much greater resolution and is really the tool to move us forward. Next slide. For therapy, the distance of radioactivity penetration, the energy deposition guides the choice of radiopharmaceutical. Beta emitters such as lutetium-177 is actively used in neuroendocrine as well as PSMA space, but alpha emitters is what is drawing a lot of attention and potentially can broaden the scope and therapeutic ratio going forward. Next slide. Finding new opportunities and theranostics may lie with targeting beyond the cancer. Targeting microenvironment is potentially possible. Technical advances in the imaging tools, including optical imaging, can broaden the scope. Cross-cancer and cross-cancer-associated markers, discoveries, and combining it with other modalities. And what really gets me excited is the ability to move this modality from the metastatic setting up to the adjuvant and neoadjuvant setting, and which I think will come in a not too distant future. Next slide. Discovering new radiopharmaceutical and embarking on this journey require multidisciplinary, cross-disciplinary collaboration. This complex slide and a complex process describe basically the iterative process that is in domain of radiochemists, radio safety, requiring GMCP facilities, and clinicians that understand the process to help move this forward. Next slide. Lessons that I've learned through my involvement in the last few years, which is really mounting a trial in a neuroendocrine tumor to provide access and the opportunities brought to us. Next slide. Understanding the pipeline for radiopharmaceutical production is important for the clinician. This is different from taking a drug from a pharmacy, because every time it is needed, it is produced because of its decaying half-life. So the clinician need to understand that well. building the clinical team, healthcare professionals are around us, people who know and understand the space, nuclear medicine physicians, radiopharmacists, they understand that well. As radiation oncologists, we can bring in the dosimetry, understanding dose and tumor targeting and the biology of the disease well, and that needs to be cultivated. Next slide. Ultimately, teaming up with our interdisciplinary colleagues to build the delivering capacity is the beginning, but building the therapeutic program that has the ability to design new radiopharmaceutical, test them, and build training capacity so the next generation oncologists understand this modality is critical. Next slide. I'll skip through the next one and the next one and move to my final slide. My take-home message to you then is that theranostics are positioned to be a standard modality in cancer care. Advances in research methods, translational science, and technology is converging to bring an accelerated path to theranostics from design to clinical application. Partnership between nuclear medicine, radiation oncology, and the professionals that we work with provide great complementary skills to research and innovation so that we can bring new outcomes and improved outcomes to our patients. Thank you.
Rebecca, it was a great talk, very, very interesting, and the subject is very interesting too. So thank you very much for giving us this lecture, this very nice lecture. I think we have just time for a very short question, if any from the audience, but we can discuss this because there are a lot of things that we can discuss about theranostics. We can have some questions and answers from you in the discussion. There is a message. So it says, hello, thank you very much for the great presentation. Is there a way to load PSMA or other tumor uptaking molecules with oxygen-releasing combinations to use while external radiotherapy to increase the biologic effectiveness?
I can't quite get the entire question. But
can we send it to her? You can see in the Q and answers. You can see it in the Q and answer, question and answer Q&A down the page.
Oh, I see. Okay, got it. I think there's I don't know of an immediate answer to that question. I think that is a very interesting strategy to reduce hypoxia. There are certainly molecular targets that can be used to detect a hypoxic fraction, and I think being able to combine that with targeting the cancer cellular tumor markers on the cancer cell to enhance the effect of both theranostics itself and potentially to target external beam radiotherapy is very feasible. In fact, I think there are some studies going on to image hypoxia at our center.
Okay, thank you very much again. So hopefully you can stay until the end for the questions and answers in the panel. I'm sure that there will be questions about this great presentation of yours. So now we go to Professor Yarnold. John, we can see you and the light is okay. So, but we cannot hear you. Do we have his voice? Oh, please unmute your microphone.
I'm unmuted.
Oh yeah. It's we can hear you now again.
Good. I'm just waiting for my slides.
No, I'm just give a short introduction. Okay. So Professor Yarnold is one of the main researchers in breast cancer in the world, and he very kindly helped. I think you began to our modern research in our department with the ABC trial, adjuvant breast cancer trial, that you started with Dr. Deshri and Dr. Rafat, both so unfortunately died. I don't know whether you heard John or not, Dr. Rafa just died about 2 weeks ago, and I'm very sorry for that. But after the ABC trial, adjuvant breast cancer trial, we went to Atlas, adjuvant tamoxifen longer against Georgia. So you helped us start the model research in our department. Well, and now our department is, I think, is one of the most active research centers in Iran, in our country. So thank you again, John, for everything and for your kindness and your being friend to us. I must say to the audience that Dr. John Arnold had very kindly sent a lot of photos from our colleagues, many of our colleagues, and also from Dr. Deshri, Professor Deshri, Professor Mortazali. And because of the shortness of time, unfortunately, we cannot show that, but he decided not to show that. But please go ahead, John, and give us your lecture. So can we have his slides?
Well, thank you, Behmen, and ladies and gentlemen, thank you for that nice introduction. And it's a privilege and a pleasure for me to participate in your webinar today. And in the first few minutes, I'll offer an introduction for those of you who are not radiation oncologists, after which I shall spend the last 10 minutes concentrating on a particular specific trial, which is testing larger fraction sizes, fewer larger fraction sizes, giving a lower total dose of radiation for women with early breast cancer. And next, please, I have no disclosures. Fine, I'll start with two schemas. The first, this one before you, showing a traditional model of fractionation. It plots the clinical responses of normal tissues that are responsible for late adverse effects, and the responses of tumors on the vertical axis against fraction size. Fraction being the term ascribed to the size of the daily dose that we prescribe to patients. And both those responses are normalized at 2 gray for the purposes of this schema, since this is the traditional gold standard fraction size, 2 gray. The first thing to note is that both responses, neither responses are linear, but they're both upwardly bending to different degrees, and a difference that we exploit in the clinic. And the traditional model assumes that normal tissues are more responsive to fraction size than all cancers. And that in that case, fractions greater than 2 gray, late adverse effects will increase more steeply than tumor control. And that's highly unfavorable, of course. So for fractions of 2 gray, this outcome is minimized, and it allows us traditionally to give the highest total physical dose to be delivered safely. Next slide, please. All right, well, okay. So the current model, which is shown here, hypothesizes that breast cancer responds more like a late reacting normal tissue. And in case I missed the fact that you may not have seen the previous slide, late normal tissue reactions certainly respond like breast cancers there. And if breast cancer is as sensitive to fraction size as the normal tissues, it means that breast cancer is equally spared by 2 gray fractions. And that means that's no advantage to patients in terms of a therapeutic ratio. And those schemas are meant to represent or to show you why fraction sizes greater than 2 gray would at least have no disadvantages for women with breast cancer, and may well have advances beyond those of convenience and cost. So the hypothesis is that fraction sizes greater than 2 gray are unsafe and effective, provided the appropriate reduction is to the total doses introduced. Next slide, please. Carry on. Yeah. So 9 clinical trials are being published, reporting 5 or 10-year results over the last 20 years. The trials have been conducted over more than 30 years, involve more than 14,000 patients. And all the results are consistent with the hypothesis that fraction sizes greater than 2 gray can be at least as safe and non-inferior in terms of tumor control to conventional 2 gray schedules. And in addition to those large trials that are shown there, there are other smaller studies, including a randomized trial conducted by Dr. Fanas Hashemi and colleagues at TUMS, that is also consistent with the hypothesis under test and with the results of these studies on the table. But we can't go through each study, there's just no time, but I want to explain how direct estimates of fraction size sensitivity have been quantified that are unconfounded by differences in treatment time between control and test regimens, because most of the comparisons have been between 5 weeks versus 3 weeks of radiotherapy, and are confounded by time when trying to understand the relationship between tissue response and fraction size changes. Next slide, please. And I'll use just one example of our UK trials, the START trial. The control schedule in women with early breast cancer, primary surgery, after primary surgery, the control schedule was 50 Gray in 25 fractions of 2 Gray over 5 weeks. And what I want to point out, first of all, on the right-hand column, the test schedules were also given over 5 weeks. 13 fractions or 13 doses given 5 times a fortnight over 5 weeks. And then the challenge was to estimate what reduction in total dose was necessary to match the late adverse effects of 50 Gray. And we considered it would lie between somewhere between 39 Gray and 42 Gray. And we tested those 2 fraction sizes that you can see there, 3.2 and 3.0. And we were able to interpolate between the two in order to identify the schedule that was iso-effective, had the same effect on the control schedule. And that allows unconfounded estimates of fraction size. And we use a parameter called the alpha beta value, which is just, we can treat as a number today to actually quantify that and use it in terms of response prediction. And basically, those estimates of alpha beta, which is what these values reflect, of 2 trials that totaled more than 3,500 patients. They started in 1986 and went up to 2003. For adverse effects, 815 adverse effects in over 2,000 patients, the alpha beta was just over 3. And you can see the confidence intervals there are quite narrow. And for tumor relapse, the alpha beta value was very close to 3, 3.5. For, say, most cancers, say squamous cell carcinomas, the alpha beta would be over 10, and very good difference. So the conclusion is that with these trials, the 2 Gray fractions spare the breast cancer as much as the healthy tissues, and that's just no advantage to patients, as I mentioned before. And that result is consistent with the other 7 trials that was on my rather busy table a few minutes ago. And the UK 15 fraction schedule and the Canadian 16 fraction regimen have been widely adopted globally for the adjuvant radiotherapy of patients with early breast cancer. Next slide, please. Well, now, with that introduction, next slide, please. So I'll spend the remaining time summarizing the 5-year outcome data of the UK Fast Forward trial that was published last year. Next slide, please. And that trial aimed to test a 1-week course of local radiotherapy to the breast or the post-mastectomy chest wall against 40 Gray and 15 fractions, which is has been the UK standard for more than 10 years now, following the START trials, in patients with early breast cancer in terms of local control and adverse effects. Next slide, please. And this slide shows the schema of the study. Starting on the left-hand side, eligible patients had invasive carcinoma of the breast of PT1 to 3, PN0 to 1, M0, requiring no lymphatic radiotherapy. In other words, they were generally patients, the majority of our patients, with fewer than 4 effective lymph nodes. That would be the criteria for which patients would be recommended adjuvant lymphatic radiotherapy in addition to the local radiotherapy. So those women eligible were randomized in equal ratios to the control regimen of 40 Gray and 15 fractions in red, and to 2 dose levels of a 5 fraction regimen that were estimated to be equivalent to 40 Gray and 15 fractions in terms of the dose limiting adverse effects. And in fact, it was the green schedule, 27 Gray and 5 fractions of 5.2, that we reckon would be what we call iso-effective for late adverse effects. And we would then be interested to know whether it was non-inferior in terms of local tumor control. Tumor control was the primary endpoint, and there were secondary endpoints as based on annual clinical assessments, photographs scored blind to treatment allocation, and patient-recorded outcome measures as indicated. In terms of sample size, we pre-specified a non-inferiority margin of absolute 1.6% increase in 5-year local control for the 5 fraction regimen versus 50 Gray. And assuming a 2% 5-year local relapse rate in the 40 Gray group and a critical hazard ratio for non-inferiority of 1.8, the sample size was 4,000 patients, and that was with 80% power and a 1% alpha of 0.025. And that small value allows comparisons between each test schedule versus control. It's a kind of a Bonferroni correction. So 4,000 patients were needed to test this hypothesis in this context. Next slide, please. And this is a table summarizing some of the baseline and treatment characteristics. And it's typical of the eligible UK population. It excludes a minority of women in our country with more than 4 or more positive axillary nodes. And in the top row, you'll see that the patient numbers are well balanced between the 3 randomized groups. In other words, 1,361, 1,367, 1,368. Then when we look at grade, we'll see that 28% are grade 3. That's representative of the grade proportion in the UK. In terms of risk group defined by either age under 50 or grade 3, that's an arbitrary classification. Those numbers are at 38, 37, 38%. You'll see that the large majority of women were treated with breast conservation surgery, only 6, 7, 8% of patients treated by mastectomy. Only a minority of patients were node positive. That was typical of the UK, about 20%. And you'll see that the large majority were ER plus, HER2 negative, 82, 83, 81%. And a small minority were triple negative, that's 8, 9%. And that about 28% had some form of adjuvant or neoadjuvant chemotherapy, typical of this population group. Thank you. Early in the study, we conducted a check of the acute skin toxicity with clinical assessments according to CTCAE in 7 centers in 150 patients. And it plots on the vertical axis the percentage of patients with grade 1 or grade 2 acute skin reactions against a time in weeks from the start of radiotherapy, up to 7 weeks. The grade 1 solid lines, the solid lines represent grade 1 erythema, and the red line is the control group, 40 gray and 15 fractions, and the dashed lines underneath are grade 2. There were virtually no grade 3 skin reactions. And you'll see that the green and blue lines with the 5 fraction schedules, there's no suggestion that skin reactions are more severe. In fact, they're less severe and they're shorter lived. And this would be consistent with our expectations for acute skin reactions. They're much more sensitive to total dose reduction than they are to the increase in fraction size. So that was good. Next slide, please. And again, next, please. So this is the primary outcome measure. The time to event analysis in over 4,000 patients in the 3 randomized groups indicated in the left-hand column show that there were 31, 27, and 21 local relapse events in those 3 arms. These are relapses in the preserved breast and 1 or 2 relapses on the post-mastectomy chest wall. That's the absolute number of events in that in the first column, the cumulative number of events, and then the percentages are in brackets. And then the second column is the estimated cumulative incidence by 5 years. That's the percentage cumulative incidence, 2.1, 1.7, 1.4, with the 95% confidence intervals. And then next, the hazard ratio. That's important in terms of non-inferiority. Both test groups, the hazard ratio, point estimates are less than 1, and the upper confidence interval is 1.44 for the 27 gray and 1.16 for 26 gray. They're both under the 1.8 limit that we set out to exclude. So we can conclude from this that both 5 fraction schedules are non-inferior in terms of local tumor control to 40 gray and 15 fractions. Regional relapses, there were a few regional relapses, but they would be out of field. But roughly there was about 0.5% of patients that had regional relapse that I'm not showing you, but they're all in the paper outline. Next slide, please. And this shows the same data on the cumulative probability plot. Note that it's truncated at 3% on the vertical axis and extends out to 7 years. And at a glance, with the red being the control, 40 gray and 15 fractions, that just gives you a visual representation of the local control, and no difference between schedules. Next slide, please. I'll go through the disease-free and overall survival. There you see there's no difference there. This, vertical axis goes up to 100% there, out to 7 years. Overall survival, next slide, please, the same. Okay, so this shows any moderate or marked clinically assessed adverse event in the breast or post-mastectomy chest wall over 5 years. And again, on the most left-hand column are the different dose schedules, 40 gray up, then 27, 26 gray. Then the first column, the left-hand column results within the green box, shows the number of moderate or marked events scored over the whole 5-year period, and the denominator is the number of assessments made over that period. And in brackets then is a percentage of those assessments that scored a moderate or marked event of any kind in the breast or post-mastectomy chest wall. And then the second vertical column shows the odds ratios. They're normalized obviously to the control group, and you can see that for 27 gray it's 1.55, and that's statistically significant. In other words, it's highly likely to be a real higher rate of moderate or marked late adverse effects. And for 26 gray, it's 1.12, and the p-value is 0.2, so that is not a significant difference. And the fourth column shows that the difference between the 26 gray and the 27 gray is highly statistically significant, and that gives us a very powerful test of the sensitivity of our assays. In other words, clinical assessments are sensitive to that 1 gray difference in total dose. That's very powerful and reassuring. Next slide, please. And that shows the same data, and again, a longitudinal analysis of for any moderate or marked event compared to 40 gray over the 5-year period. And in the dark gray, that's patients recording no adverse effect. In light gray, it's mild adverse effect. The pink or magenta is moderate, and there's only 1 or 2% with a marked effect. And you'll see that it reproduces the differences I've just shown you in the previous slide. A moderate and significant excess in 27 and near equivalence for 26. Next slide, please. The next slide shows you the patient-reported outcome assessments in 1,700 women that had 5-year assessments. I won't go through the individual outcomes. I hope if you're interested, you can read some of them. Basically, change in breast appearance, whether the breast is smaller, whether it's harder, whether it's tender, and the upper panel, if green, that shows the comparison of 27 gray versus control, and the lower in blue is the comparison of 26 gray versus control. And you can see overall there was a trend for the odds ratios shown with the horizontal lines in relation to the vertical axis of hazard ratio of 1, odds ratio of 1. Overall, there's a trend for the odds ratios to fall to the right of 1 for 27 gray. In fact, 2 out of the 9 measures have a lower 95% confidence interval that is greater than 1. And for the trend to be less evident at the 26 gray dose level, with all 95% confidence intervals overlapping 1. Okay, so that's very consistent with the clinicians. And in fact, the dose response between the 26 and 27 gray is statistically significant, even for the patients, remarkably. And from these data, we can estimate fractionation sensitivity quantified using the alpha beta for a range of late adverse effects. Again, you can see for any of the clinician reported adverse effects that I've just shown you, the alpha beta estimate is 1.7. For the photographic change in breast appearance that I haven't shown you, is 1.8. For the patient reported moderate marked change in breast appearance, which I have shown you, it's 2.3. Now, all those estimates are closer to 2 gray than the 3 gray that was predicted at the beginning of the trial. Although the 95% confidence intervals for each endpoint in all the earlier trials, they do overlap with this. Now, the implications of these results are considered in the next slide, and we're coming close to the end now. Next slide, please. Now, this slide examines the effects of different alpha beta estimates on the equivalent total doses in 2 gray fractions compared to a standard 50 gray. So in other words, you can apply those alpha beta ratios to convert those schedules shown on the left to a dose intensity that they would be equivalent to if they had been given in 2 gray fractions. And you can see, assuming an alpha beta ratio of 2, which is what the trial generates, the equivalent total dose in 2 gray fractions is 47 gray. And that compares to 50 gray, which is being the standard gold standard. So in other words, it's gentler than 50 gray. We predicted it was going to be the alpha beta ratio of 3, but you can see that clearly with alpha beta ratio of 3, then the equivalence is not met. Even if the alpha beta ratio is 1.7, if you look at the bottom right-hand corner, even if the alpha beta ratio is 1.7, 26 gray in 5 fractions is equivalent to 49 gray in 2 gray equivalent, still very much comparable with 50 gray. Okay, so the clinical results are highly reassuring. Next slide, please. Just one slide on selected subgroups here. In 604 patients under 50, you see it's not an age profile similar to Iran. In those 604 patients under 50, there were only 14 local recurrences. And there's a slight imbalance between the two numbers, but the numbers are so small that you cannot say anything about that. If you looked at 1,100 patients of grade 3 patients, there are 20 in the control group, and you'd expect a combination of 40 in the two experimental groups, put them together. But there's only 15 plus 8, which is 23. At least that's reassuring trend. And if you look at the 333 triple negative patients at the bottom, there were 10 recurrences in the after 40 gray, and you'd expect then 20 other two test groups combined, and there are 8. So that trend is also reassuring. So as things stand at the moment, there are no reasons to identify. There's no way we can identify patients that are more or less suitable for this regimen. So the last slide, but the one slide, next slide, please. In conclusion, then moderate hyperfractionation is safe and effective. I mean, both test schedules in fast forward are non-inferior to 40 gray and 15 fractions for local tumor control. And for later adverse effects, 26 gray and 5 fractions is very similar to 40 gray and 15 fractions, equivalent to about 47 gray and 25 fractions. And that's the 27 gray is pretty well matches the effects of 50 gray. The UK has adopted 26 gray and 5 fractions for local adjuvant radiotherapy. And if anybody's interested in the fast forward protocol and the radiotherapy planning pack, they're freely available if you just log on to our website and search for fast forward page, and you can download those for free. And I think the online paper and all supplementary papers are online in the Lancet. Finally, last slide, I acknowledge on the last slide the patients and all our co-investigators, the oversight committees and the sponsors, and of course the funders. And I thank you, my audience, for listening to me. Thank you.
Thanks, John. Your talk was, like always, very teaching, very great, and I liked it. I loved it. So, is there any short question from the audience?
I've got an anonymous question. I've got someone that's asked a question, if I can answer that whilst we're going. The question is, the good question, what was the rationale for designing two arms, 26 and 27 in the fast forward trial? Is one grade total difference that much important regarding adverse effects? Well, thank you for that question. I mean, I hope that the data I've just shown you would show that actually, yes, that difference is important. Is the difference between 5.2 and 5.4 gray is actually very significant, which is why radiation oncologists take so much time and trouble over making sure their dose deliveries are accurate. And the reason for choosing two arms, we knew that they were going to be different based on our previous experience, and we wanted to actually identify that dose level which was equivalent to 40 gray and 50 fractions. We didn't just want to guess and hope that we'd guess right. By having two test dose levels and being able to interpolate between them or project slightly on either side, it guarantees that we can identify the ISO effect and then directly estimate the alpha beta. I hope that's satisfactory.
Yes, John. It's one of the people here, Dr. Farhan, in fact, one of the panelists, is asking that it was used for the early stages, and one of your slides showed that. It's talking.
Yes, it's P1 to 3. In practice, the median tumor size in the UK, the median, that is 50%, is 2 centimeters less. The pathological tumor size is small. And so the number of patients, it's all listed in the tables in the Lancet in great detail, but the number of patients with tumors more than 3, in the range of 3 to 5 centimeters is small. And so this is, that is the nature of the UK. It is certainly representative of the UK population. You have to judge from the manuscript to what extent it is representative of the Iranian population, and to the degree to which that is actually important in directing your own recommendations.
So there are 3 questions for you. Because of the shortness of time, we cannot have any more questions. Please, could you, John, are you seeing the the questions?
I can type an answer to them. I'll type an answer.
Go on and answer. But if you can, just very...
Okay, all right, there's a second question. About the techniques. That's a complex question.
Yes.
There'll be no different to yours, and they're all outlined in the planning pack. If you go onto the ICR website, and if you can't find it, get Behmn to give me an email or send me a WhatsApp, and I'll get more details to you. I can send the documents out to you, and you can circulate them. But all the techniques and the dose constraints are outlined there. Well, actually, then someone else has taken their question away. So I think there are no other questions then, unless there's something I've missed.
There was 2 more questions.
All right, under chats. All right, there's a difference between Q&A and chats. Behmn, I think you have to select what you want me to comment on, depending on the time, because you've got other speakers giving valuable talks.
Yeah, we are short of time, so please go and answer. Well, you go on and answer, please.
No, I think that due to I'm just thinking. I don't think there's there's nothing else specific. I'm happy to get into email correspondence, or I'm happy to type in answers.
Or could you wait until the panel and participate in the discussion? So we will try to answer these questions at the discussion at the panel.
Yeah, I can type answers in as well.
Okay. Thank you very much. It will be good if we discuss these issues, of course, shortly in the panel. So thanks again, John, Professor Yanol, and I hereby thank the Darian Selamat company, representative of Ipsen in Iran, who's kindly sponsored us, and we have a clip from them. Okay, thank you again, Darian Selamat, representative of Ipsen in Iran, and Ms. Dr. Sahafi, who very kindly helped us a lot for this webinar. So now we go to Professor Peter Jong. Is Peter on? Can we see him? Okay, hi Peter again.
Hi.
So we were fellows together in Princess Margaret Hospital in 2002 and 2003. He very much helped me very much. I was a fresh fellow. He was a new fellow, and he was 1 year ahead of me. So he helped me a lot. He and her very nice wife, Barbara Miller, who are both now in Princess Margaret Hospital. And Peter is now responsible for the fellowship program in Princess Margaret Hospital. And he's a great guy. He's very kind, very friendly. And I thank you, Peter, very much for accepting to be here. Please, can we have the slides?
So thank you very much for the invitation to speak at your webinar. And so my talk is entitled IGRT in Radiotherapy, focused on MR-based simulation and prostate cancer. These are my disclosures, and my thanks go to my colleagues who have helped me with data and slides, and also to Professor Behmn Haddad for the invitation to speak. Next slide. So an overview of my talk. I'm just going to briefly go over the results of IGRT in prostate cancer, a brief overview of MR in prostate cancer radiotherapy, and then move on to our experience at the Princess Margaret Cancer Centre with the MR-Linac, and then future opportunities in NMR-based treatment in prostate cancer. Next slide. So, as many of you may be aware, there have been multiple randomized studies examining the dose fractionation and modern external beam radiotherapy for prostate cancer, and this is the PROPHET study, which was a Canadian-led international study that randomized over 1,200 patients to 60 gray in 20 fractions versus 78 gray in 39 fractions. It was a non-inferiority design, and the biochemical control at 5 years was estimated to be at 85% in both arms, thus establishing a non-inferiority, with similar late toxicity for GU and GI. This was CT-based for target delineation and treatment delivery. Next slide. And similarly, more recently, the Scandinavian study of ultra-hyperfractionated radiation versus conventionally fractionated radiation compared 42-70 in 7 versus 78 in 39. And 5-year median follow-up with 5-year failure-free survival, i.e. biochemical survival, was 84% in both arms. And again, a non-inferiority design with relatively similar rates of late toxicity. And finally, the hyperfractionated versus conventionally fractionated radiotherapy. And this was a slightly different design in that it was aimed at discovering whether there was superiority with a moderately hyperfractionated dose, but estimated to be a slight dose escalation over 78 gray and 39 fractions. 820 patients, and in this study, superiority was not proven statistically, with a 5-year relapse-free, i.e. biochemical-free survival of 80.5% in the experimental arm. The other issue with this study was the fact that the late grade 2 or greater toxicity was deemed unable to be confirmed to be non-inferior to the conventionally fractionated radiation. And therefore, there was a suggestion from this data that treatment of the whole gland with moderately hyperfractionated dose-escalated radiation had reached a maximum. So dose escalation to whole gland may have been maximized without an increase in toxicity. And most of this data is based on CT simulation for target delineation, and usually CT-based treatment delivery, i.e. cone beam or similar. We all know that MR in prostate has superior soft tissue definition, and in particular intraprostatic lesions are particularly well demonstrated. And multiple studies have shown that there are reductions in intra-observer differences for target delineation and a high degree of accuracy when targeting the whole gland with MRI. However, this is relatively resource intense. One needs an MR simulator, and for a whole gland approach, there may be relatively limited gain in therapy. So then the Dutch FLAME trial examined the concept of a focal boost within the prostate at the same time as more conventionally dose fractionated to the whole gland. And this was a superiority designed trial in which 571 patients were randomized between 95 gray and 35 fractions versus the standard dose, which was 77 gray and 35 fractions. And the 95 gray was delivered to an intraprostatic target. This showed that there was an improvement in 5-year biochemical disease-free survival from 85% up to 92% for the experimental arm, with a median follow-up of 5 years, with reasonably comparable rates of toxicity, greater than grade 2. And this was based on CT-MR fusion for target delineation. So at the Princess Margaret, we actually also have done a similar approach in a smaller phase 2 cohort trial, where we actually had a non-randomized comparison of focal integrated boost to tumor target intraprostatically using MR and CT fusion for target delineation. We also had another arm where we had MR-directed brachytherapy to an intraprostatic targeted lesion. And the data is not mature enough yet to provide biochemical control rates, but at least the early late toxicity data would suggest that they are fairly comparable in terms of late toxicity. So what about the MR-Linac? So this is, I'm going to really talk just about the Elekta-based system. As you may well be aware, there are two main MR-Linac systems that are available commercially. One is through Elekta, and the other one is through ViewRay. They're slightly different technologies, but the principle of using MR for simulation planning and treatment delivery verification is similar. But with an MR-based system for prostate cancer, the simulation it gives a higher degree of definition between surrounding soft tissue versus the prostate and the OARs that are surrounding this. There is an opportunity for daily adaptive treatment replanning and actually delivering the so-called plan of the day as an adaptive approach. There is also the opportunity for treatment response assessment. But does this represent a major advantage over a CT-based system? So there are some challenges in terms of radiation for prostate cancer that the MR-Linac is perhaps in some ways better equipped to overcome compared to a CT-based system. So target delineation of MR is likely better. Intrafraction motion may also be better. Accounting the deformation and rotation of the prostate gland and the surrounding organs at risk is probably better for MR versus CT. And relative motion of the prostate in some vesicles, indeed with the better soft tissue definition, is probably superior. Contributing factors to prostate motion include rectal and bladder volume changes over the course of the treatment, i.e. the so-called intrafraction prostate motion is relative to the interfraction organs at risk motion. And there is an element of patient motion in this when this becomes a little bit more apparent in the next slide. So there are limitations to the MR-Linac system. Could you go back one slide, please? So there are limitations to the MR-Linac system in that it's a time cost. For most CT-based systems in terms of treatment delivery, the treatment is delivered over an average of about 10 minutes. And for MR-Linac-based system, we're talking about upwards of, on average, about 40 minutes as reported in literature thus far. Beam gating solutions may solve some of these issues in the MR-Linac system. So this is the Elekta Unity system with the Linac actually in the bore, surrounding the bore of the MR with the treatment couch, and the treatment couch is very fixed in that there's only a bidirectional maneuver, i.e. it can go into the bore and adjust superiorly and inferiorly versus the isocenter. There is no translation of the couch in terms of couch height, etc. However, this is compensated for by the MLC and the adaptive replanning. So to date, this is some of the experience that we've had. We've chosen to go with ultra-hyperfractionated dose scheduling for the patients we've treated. And to date, we've treated 38 prostate patients to a total of 213 fractions. So our total session average time from start of the patient going into the room to leaving the room is about 50 minutes. with a fairly broad, wide range, compared to the CT system, which is on average about 10 minutes. Localization to verification image is on average about 23 minutes, and then verification image to beam on is another 10 minutes. And this takes into account all of the QA checks that need to be undertaken, because each treatment plan is done on the day of the treatment. Physician contouring, again, can be variable depending on the complexity with which the prostate is visualized. So even with MR, sometimes it can be challenging, particularly with patients who have relatively indistinct external borders of the prostate. So in my view, the role of MR-Linac in prostate cancer radiation, these are a few selected sort of case scenarios that I think are probably more pertinent. Certainly hypofractionated, ultra-hypofractionated whole gland SBRT is a consideration. There are fewer fractions, so therefore, if you're taking 50 minutes to treat a fraction, if you're treating the patient between 5 and 7 fractions, as most ultra-hypofractionated schedules these days are, that's not a lot of time cost for the patient. One does have more gain from the daily adaptation compared to potentially a standard Linac-based system. And one might choose to treat such patients who have organs at risk that are in unfavorable positions, for example, with small bowel nearby, or sigmoid nearby, and where avoidance of excess dose may be critical. The other avenue of investigation, in my view, is a tumor-targeted intraprostatic boost approach, similar to the FLAME study, similar to our HDR focal boost approach. And then the third possibility is the treatment of pelvic oligometastases, particularly lymph node metastases in the pelvis, with stereotactic body radiation doses in this sort of scenario, again with better visualization of OARs and also potentially the target. And then this does allow for also the ability to calculate dose actually delivered to the patient, and allows us to participate in radiation response correlation and assessment. However, in my view, because of the issue of the time taken and the efficacy or the time efficiency of the MR-Linac system, for whole gland, even with hyperfractionated approach, I do believe that it is still somewhat limited. So speaking about intraprostatic boost, this is just some early work we've been doing in terms of trying to derive a PTV margin in order to achieve a GTV intraprostatic boost on the MR-Linac system. And this is actually 3 patients who've been treated with whole gland treatment, SBRT, and their mean and the range of displacements of the GTV versus the prostate. So this slide actually illustrates the issues that we have because of the long treatment times in terms of, for example, the GTV and its motion. So at time 0, at the initial scan, the GTV is outlined in red. And then at 34 minutes, which is at the verification scan about to start treatment, you can see that the GTV is actually moved down to where the yellow outline is. And then at treatment time, at 43 minutes, the GTV is roughly in about the same position as it was at 34 minutes. So because of the long treatment time, there is an increased opportunity for any GTV within the prostate to actually move, just as the prostate itself may move. And these are potentially relative positions of the 2 structures. So this is just an example of the first oligometastatic patient that we treated on the MRL. This was a small lymph node that was treated on a clinical trial that we have going here. And the aim of this study was to deliver 30 gray in 3 fractions, so 10 gray per fraction. As you can see, or it may be difficult to see, but right next to the GTV, which is outlined in red there, the ureter is there, and nearby is small bowel. And this is comparing with the CT sim image. Now, if we go to the next slide, this is a similar but a different patient, and gives you the idea of what such a patient might look like on the standard LINAC with cone beam CT as treatment verification and delivery. So here on the MR, one can see quite clearly the small bowel relationship and the target relationship to that, whereas on the cone beam, often the borders of the OARs nearby, particularly small bowel and other soft tissue structures, is certainly less well seen. So this was just the example of the anatomy of the patient that I showed in the initial slide of the Roxanwebinar treatment. And then this was just the dose distribution on the adapted day 1 plan. So each day was treated with a slightly different dose distribution for that day. So as I mentioned before, this does actually allow us to better document and clarify exactly what the dose is that is delivered to the patient. And this may have some application in determining issues such as local failure and whether there was inadequate dose delivered to gross tumor within the treatment volume, based on potential risk of intraprostatic motion or intrafraction motion. So the idea here, and this is still a work in progress, and we're still figuring out how to do this, but we compute beams based on the imaging collected during beam delivery. And then there's an automated process for deforming each fraction's dose to the reference MRI in order to actually determine the true dose delivered. So this helps us potentially in quantifying the difference between the accumulated planned and delivered dose. And this slide just shows you where the dose changes from baseline planned versus delivered. So finally, I believe this is the last slide. This is a couple of papers, one that we published last year, and also a group from the Netherlands published looking at changes in T2 and diffusion weighted imaging. And the findings were relatively similar in that there were relatively quite obvious changes in the T2 weighted imaging, and particularly the ADC maps of the prostate during the treatment. So in the mildly hyperfractionated tumor boost study that I mentioned previously, you can see that on the top panel there. These are the left panel. Sorry, these are 4 different patients, all with changes with the ADC over from week 0 through to week 6. And then on the right-hand panel, ultra hyperfractionated tumor boost, and similar findings that weekly MRIs did show some changes. And of course, these do and will need to be correlated with subsequent downstream biochemical response and correlation of whether this can be successfully used as an early treatment response assessor. So in conclusion, I hope I've demonstrated to a certain extent that in prostate cancer IGRT that MR enables improvement in delineation and treatment of intra and extraprostatic targets. The MR LINAC allows adaptive radiotherapy, but at the expense of treatment process efficiency and patient throughput. So that's, in my view, at least for whole gland radiation, it is a major limitation. And MR-based simulation planning and treatment delivery will also facilitate further refinement of RT and future opportunities for translational research and response assessment in prostate cancer radiotherapy. Thank you very much for your attention.
Thank you very much, Professor Chang.
I am Dr. Farhan, a colleague of Professor Haddad, and he is also my mentor. Thank you very much for a nice presentation. I have a question from you. Is there a reason you chose prostate cancer patients for MR-Linac-based treatment? For example, in head and neck area, we are more dependent on MRI. We use MR fusion to define lymph node levels and also tumors. Is there a reason you have chosen prostate cancer for your study?
So it was actually a practical consideration from a point of view of it was really the first site that we as a department decided to use, because we had very well established process in terms of standard Linac. We also already had a relatively well established not MR Linac, but an MR guided program where we had a separate MR simulator that was linked to an MR Brachy suite. So just for us, it was a particularly relatively straightforward process to change from a CT based system into the MR system. But as I alluded to in my talk, I don't think that's where the future is in terms of MR Linac treatments, because I don't think that there's a huge gain to be had, particularly for whole gland treatments. But I do think there are parts of prostate cancer treatment that are very well suited to the MR based and MR Linac system.
As you mentioned, it's a time-consuming treatment modality, and patients may get low back pain after this whole 40 minutes time, yeah? And patients may become intolerant to this. And as you mentioned, it has a limited role.
Well, I would say that for the patients that we've treated so far, so during the time that we've been doing this in the prostate cancer patient population, we have had a study going on that it has actually examined patient comfort and tolerability for each treatment. So we will be publishing that data sometime in the future. And in fact, Dr. Milosevic, my colleague, who's actually in charge of our kind of MR program and our research program, is the PI for the tolerability trial. For other sites that we're actually moving on to, we're investigating liver and oligometastases, not just in prostate cancer, but in all different sites. And then the next ones we're moving on to are pancreas, SBRT, and anal canal cancers.
Thank you very much for your nice presentation. And
Thanks, Peter.
I'm going to invite next speaker, Professor Michael Milosevic from University of Toronto, Canada. He's going to talk about immune modulation to enhance radiation treatment. Hi, Professor Milosevic. It's a great honor to have you in your webinar. It's the area of my interest also, the immune modulation, abscopal effect, and it's always my interest. I want to know, is there, I have always mentioned, how can we predict which patients will have good response, will have good immune response to treatment? Do we have a immune map to predict this response, immune radiation in patients? So I'm going to hear your nice speech. Thank you.
I'm Mike. Are you? I think you are still the responsible person for radiotherapy quality control in Canada.
Yes, that's another hat that I wear at the same time. Yeah, that's right.
So that it would be great if in some time in future we can have a talk with you, a webinar just like this one, about quality control in radiotherapy and have your advice, because that's a big issue here too. And we are, of course, doing Quattro and other things with International Atomic Energy Agency. So that would be great to have that, but well, there are a lot of questions coming, so we cannot talk about this issue in the discussion, but we will focus on your immune modulation speech. Please go ahead.
Thank you very much. So I'm actually gonna change direction a little bit from the talks that we've heard so far. I am going to talk about some work that we're actually quite excited about that's coming out of the lab right now. It's come out of the lab over the past few years, and it's pushing into clinical trials at this point. And from my perspective, it is actually quite an exciting space to be in. It's going to focus really not so much on the abscopal effect, which is a hot topic of conversation these days, but really on how we can use immune strategies to improve the curative potential of radiation treatment in patients who present not with metastatic disease, but with potentially curable cancers. And you know, a lot of the work that has happened within radiation oncology over the past many years to improve the curative ability or the way in which radiation works to cure cancer has focused on advances in technology, image guidance, altered fractionation schemes, all of which have been hugely important and very valuable and have led to some really big advances. We've heard a lot of these today from the various speakers. But I personally think that we've missed an opportunity over the years to really capitalize on understanding how radiation works at a biological level and intervening strategically to improve the effectiveness of radiation. So the focus today is on, you know, the immune response to radiation treatment, which I think is an area that we're just learning so much about right now. And I'm really going to focus on, as I said, some of the data that we've been acquiring in the lab, which is a little different than what is happening elsewhere and what a lot of the clinical trials are focusing on right now. I have nothing to disclose of relevance, and go forward, please. Thank you. So I think most people here today listening understand that immune oncology is exploding right now, that this is an area of research that is expanding at an accelerated rate. And this slide is old, it's a couple of years old right now, but it illustrates the exponential growth in the number of clinical trials relating to immune oncology that have happened over the past 10 years. In 2011, there were just a couple of trials ongoing, and now it's in the thousands if you extrapolate that number from 2017 forward. And this really indicates, you know, where our field, the field of oncology, is going in general, and the fact that, you know, we as radiation oncologists need to understand this and capitalize on the opportunities that this presents. And, you know, like many new treatments, like many new drugs or combinations of biological therapies that come out, the benefit of these things often is not in their capacity to influence tumor response as standalone drugs, but rather their capacity to work in combination with other forms of treatment to improve outcomes, to improve tumor control, to address metastases. And this, again, is something that we shouldn't be surprised about, but it is reflected in this slide, which shows that most of the trials that are being done, many of them at least, are with combinations of immune checkpoint inhibitors, these PD-1, PD-L1 inhibitors, together with, you know, other types of treatment, either other checkpoint inhibitors like CTLA-4 or chemotherapy or even radiation treatment. You know, we're beginning to see studies where radiation treatment alone or radiation plus chemotherapy are being combined with these agents to hopefully improve outcomes. Next slide. And, you know, probably the best known of these, the one that really shook up the community and illustrated the clinical potential of this kind of approach, targeting some aspect of the immune response while we're using curative intent radiation, is this trial that was published a couple of years ago in the New England Journal of Medicine, the Pacific trial in patients with stage 3 non-small cell lung cancer who received chemoradiation treatment, potentially curative treatment, and then adjuvant PD-L1 inhibitor afterwards. And I'm not a lung cancer expert. Dr. Baziak, who's coming next, can talk probably a lot more in detail about this, but it really illustrated the potential of combining these kinds of strategies with radiation treatment. There was a significant survival advantage. But, you know, as we talked about just a minute ago, not everybody in this trial benefited. There was probably only about 30% or so of patients who had a benefit, and we don't really understand how to select patients who are going to be have the greatest benefit from these forms of therapy. I would say as well that we don't actually quite understand the biology of what's happening here. These trials have been moving forward without a clear understanding of what we're doing in patients. They're very empirical in nature. They're being driven by what is perceived to be an opportunity to combine them with radiation, but really without thinking about the implications of doing that on a broad scale biologically. And we as radiation oncologists have to think not only about the effect of these combined treatments on cancer control, we have to think about the effects of these combined treatments on side effects as well, because if all we do in the course of our treatment is improve tumor control and shift the side effect profile in parallel, so we get better tumor control but more toxicity, we really haven't benefited our patients. What we really need to do is expand that therapeutic window by pushing up tumor control and survival and pushing down the toxicity profile. And, you know, these immune checkpoint inhibitors, while often well tolerated in patients, can have some pretty significant side effects that can affect every organ system in the body. And, you know, I was just looking online the other day, and there's now a lot of educational endeavors out there to really inform, for example, emergency department physicians about how to deal with patients on immune checkpoint modulators because of the potential toxicity that these things can bring to patients, and toxicities that are not commonly recognized. So I think this is an important thing that we need to factor in, especially in many of our patients that were treated for cure, where we're pushing where we're pushing doses with radiation to the limits of toxicity already. Next slide, please. So just to touch on that quickly, very briefly about the biology of what's happening, and this is a very simplified slide. You know, we know that radiation has complex effects on the immune system. It can either suppress the immune response or it can actually activate the immune response under different circumstances. But probably what happens in most circumstances is that irradiation stimulates tumor cells, this is depicted in the left half of this picture, to produce a whole bunch of cytokines and chemokines that are then very active in drawing immune cell populations into the tumor during and after radiation, T cell populations, for example. And these T cell populations can have a wide range of effect depending on how they're either activated or suppressed. And one of the dominant things that happens is that, you know, the PD-L1 and PD-1 receptors are also upregulated by radiation, and that combination actually can suppress T cell function and other immune cells in the tumor, so they don't have the same kind of cell killing effects or downstream effects. And by blocking that PD-L1, PD-1 interaction with these kinds of drugs, you release the T cells to become more active and stimulate a wide range of immune effects. But there's another cell population that has been recognized only recently, and our data, as I'll show you, suggests that this plays a very important role in the radiation treatment response, in addition to what we've just talked about with immune checkpoint. And this is the role of these cells called myeloid-derived suppressor cells. And these are little tiny, almost neutrophil-like cells that are upregulated during radiation treatment. And in general, in patients with cancer, there are many reports in the literature of people having high neutrophil counts, and high neutrophil counts being associated with bad outcome. In fact, many of those cells that are being categorized as neutrophils are probably circulating myeloid-derived suppressor cells. And these cells have two basic functions. They probably have more, but two. One is immunosuppression. So once they're in the tumor microenvironment, they also suppress the immune response. The second thing is that they stimulate, they release a whole bunch of chemokines and cytokines during and after radiation that actually protect the cellular environment from the damaging effects of radiation. And some of the best work in this regard has come from Martin Brown at Stanford, showing that the response of these cells to radiation is actually protection of the tumor vasculature from the damaging effects of radiation, so independent of the immunosuppressive effects. So we became quite interested in one of these pathways, one of these chemokine pathways that is active in drawing these myeloid-derived suppressor cells into the tumor. And this pathway, this CXCL12, CXCR4 pathway, there's a number of reasons to think about it. I mean, it was first discovered as a cofactor in HIV and HPV infection several years ago. My interest in it stemmed from my interest in tumor hypoxia, because this pathway gets upregulated by hypoxia in tumors. It also gets upregulated by radiation treatment, and it's involved in trafficking of these myeloid-derived suppressor cells. Interestingly, there are several reports in the literature that show that in addition to bringing these immune cells into the tumor, it also may be important in trafficking of tumor cells that express the receptor CXCR4 from the tumor to sites of metastatic disease. So it has this kind of dual function that's described in the literature from a clinical perspective, at least in terms of immune response and metastases. And the other thing that's quite attractive is that this is inhibited by a commercially available drug called plerixafor. You can buy this drug, it's available. So this sort of gets back as well to the whole idea of recycling drugs that are already out there for other purposes, right, that we heard about earlier. And we chose to study this in cervical cancer because it's a long-standing interest of mine, and there's a global need to really continue to invest in radiation for cervical cancer. But it's also important because the patients that we treat with radiation, even best practice radiation treatment, still are at risk of local recurrence, and also are at risk of developing metastases. And we know these tumors are also hypoxic. So there were a number of factors that came together that made us look at it, first of all, in cervical cancer. Next slide, please. And one of the challenges of doing this kind of research in the lab is coming up with a schema, a strategy, a research approach that likely is to translate to the clinic. So often preclinical studies don't end up moving into the clinic and producing any kind of real benefit. So we took an approach that others have described in the literature, where we actually treat cervical cancers that we'd get from our patients with cervical cancer. We implant these tumors, these biopsies, into the cervix of a mouse. So these are human cervix cancers implanted into the cervix of a mouse. We let these grow, and then we do image-guided radiation. We have a very specialized, we're fortunate to have a very specialized small animal imaging and a radiation facility. So we can do image-guided targeted radiation treatment of these implanted tumors. And we do that with concurrent cisplatin chemotherapy, which is the standard of care in the clinic. The only thing, I joke sometimes about, the only thing we don't do for these patients that differs from the clinic is we don't do brachytherapy afterwards. But otherwise, the care that we provide them in relation to treating these tumors reflects what we do in the clinic. Next slide, please. So this is a cumulative plot of about 10 experiments over the course of 5 or 6 years, looking at tumor growth delay with the addition of this drug called plerixafor. And you'll see these are long experiments. They take half a year or more to do, just because of the way in which these tumors grow and respond to radiation. But the red line is our standard of care right now. That's radiation and concurrent chemotherapy. Daily fractionated radiation with concurrent cisplatin. We only do 3 weeks, but otherwise it's very similar to the patients. The blue line is radiation alone, and the purple line is the addition of plerixafor, this CXCR4 inhibitor. And you can see that by blocking that pathway, we actually enhance tumor control quite substantially in these patients. And in fact, the difference in tumor control with the addition of plerixafor is greater in our experiments than the addition of cisplatin to radiation alone, which of course created a huge stir 20 years ago when those data actually were in the clinic. So we're actually quite excited about this, and it is an absolutely repeatable result in these tumor models. Next slide, please. And we've also shown, this previous slide was with concurrent plerixafor during radiation. This slide just illustrates that you can do it concurrently. You can add plerixafor during the 3 weeks of radiation, or you can add it afterwards. The yellow tumor growth plots at the bottom of that slide there represent plerixafor that's added for 3 weeks after you finish radiation and chemotherapy. And if anything, the growth delay is better when you do it that way rather than doing it at the same time as radiation and chemotherapy. And we did this study because there may be some theoretical reasons why in a clinical trial, you might want to do it afterwards rather than at the same time. We also looked at a bunch of biomarkers to understand what was going on, and this gets back to the mechanistic side of things. So on the left, first of all, you can look at either the top or the bottom. They're basically the same. Let's look at the top. That's with concurrent plerixafor. The bottom was with adjuvant plerixafor. They don't change very much. But if you look at the top, the left set of plots is what happens to expression of CXCL12, the gene itself, when you treat patients with radiation. And it goes way up as soon as you start with radiation. And other people have reported this as well. You know, in the radiation community, we really don't know very much about what happens when we actually use radiation to treat a tumor. We don't know what happens biologically because we only usually have biopsies from before we start treatment. But when you treat with radiation, this pathway gets way upregulated, and that results in the recruitment of these cell populations. So if you look there, the LY6G myeloid-derived suppressor cell population and macrophages are attracted and come into the tumor in response to this upregulation of the pathway. Interestingly, we also see upregulation of PD-L1, so one of those immune checkpoint modulators at the same time. So this becomes a very interesting area to think about. These tumors, when we implant them in the cervix of a mouse, produce lymph node metastases, just like happens in patients. And you can see that picture on the left there, which is an image showing these little tiny lymph node metastases that are just exactly the same as what we see in patients in the periodic area. And what we were able to demonstrate is that there's actually a reduction in the formation of these metastases with the addition of plerixafor, and this just shows two different tumor models. Again, the red is radiation and cisplatin together, and purple is with the addition of plerixafor. So again, from the potential of primary tumor control and metastases, there seems to be something here that may be very, very important and very exciting to think about. And finally, you know, coming back to the issue of toxicity, there are, again, we don't want to do anything that's going to increase toxicity in these patients. So we did two assays, again, very repeatable studies here, looking at acute intestinal toxicity and late intestinal toxicity, which are really the dose-limiting toxicities in women with cervical cancer and prostate cancer and a bunch of other tumors. And in both cases, when we add this drug, we see a reduction in toxicity, a reduction in the injury, normal tissue injury associated with radiation treatment. So we're not the first to describe this. Others have shown it in lung cancer and other tumor types as well. But it's actually really interesting to us because with this drug, it seems almost too good to be true, but it's very reproducible. We've seen an improvement in primary tumor response to treatment and a reduction in the side effects that could be associated with radiation at the same time. So what are we doing next with this? Well, we're looking to see in other tumor combinations in the clinic. We actually have a study that's about to start where we're actually getting blood samples from patients undergoing radiation to see if this pathway that we've just talked about is important. We're really interested in looking at combinations of CXCR4 inhibitors and PD-1, PD-L1 inhibitors because, you know, as I just said, we saw upregulation of PD-L1 with radiation. It may be quite interesting to put these together. We have collaborations with a drug company in the US looking at a more compatible CXCR4 inhibitor for patient use that you could take as a tablet once per day. And there are probably two clinical trials that are going to start very shortly. One at Princess Margaret, the schema for which is shown on the right side. And we've had a lot of interest from the US NCI and the Canadian Clinical Trials Group in a phase 2, phase 3 study in this space. My personal belief is that this is not restricted to patients with cervical cancer, that this is a phenomenon that will apply across tumor types that we treat curatively with radiation. Next slide, please. So this is a summary, basically, of what I've said, that tumors adapt to radiation by upregulating this pathway that leads to the accumulation of these immune cells, myeloid cells in particular, that promote treatment resistance. You can inhibit this very easily with a drug that's commercially available, leading to improved outcomes for patients and reduced toxicity. And the biggest thing we need right now that I alluded to just a minute ago is a more patient-friendly once-a-day tablet that they can take while they're getting radiation or after radiation. Next slide, please. And thank you to everyone who's involved in this work. All the work I've shown you very quickly has been the cumulative effort of a lot of different people in the clinic and the laboratory, to whom I'm very gracious and thankful. And I'd also like to thank Behmen and everyone else for inviting me to talk about this today, something that I am quite passionate about. Thank you very much.
Professor Milosevic, thank you very much for your nice presentation. It's a great success and development in cervical cancer patients. I'm going to ask you, do you routinely use this pyloric support for all your patients, or it's at the present time at the research level? Is it commercially available for all patients? Do we do it as a FDA approval or any approval?
Yes, so it's a drug that's FDA and Health Canada and widely approved for use for bone marrow transplant purposes, because one of the other effects of this drug, by blocking that pathway, the CXCL12, CXCR4 pathway, it also leads to release of bone marrow precursors from the bone marrow. So people who are having autologous transplants, bone marrow transplants, in addition to getting GCSF and other stimulants, often are given plerixafor at the same time to help with harvesting those stem cell populations. So you can buy the drug. It is commercially available. It's FDA approved for that indication, not for this indication. The challenge with it is that it has a very short half-life, and it has to be given intravenously. So in order to use this in cancer patients, say over a 3-week period, they'd have to have wear a continuous infusion pump or something like that. And that's a barrier right now. It's not a huge barrier. It would be far better to have a tablet that the patients could take once a day. And that's what we're negotiating with this, this bio company in the US to actually acquire, to move this into clinical trials. So it's doable. The drug is available. It's just that it's not ideally suited for cancer patients right now.
And the second question, do you have reduced your total dose when you use this drug concurrent with radiation?
So we don't think we're going to have to, because of the data I showed you about radiation side effects, right? So the reason we did all those experiments was to try and evaluate whether or not the addition of the drug would increase the sensitivity of the normal tissues to radiation, in which case you have to reduce the dose. And that, leads to questions about whether you're really benefiting patients at the end of the day. But we think, in reality, that we're going to see some protective effect of this drug on both acute side effects and late side effects. We've shown it, others have shown it as well. So in my view, we don't have to reduce dose. The plan right now is to use standard dosing regimens and treatment techniques and simply add the drug and look at outcome and toxicity down the road. Of course, we will do a phase 1 trial to be sure that that's true. But I mean, that's the plan going forward.
Okay.
Thank you.
Mike Milosevic. It was a great talk and very teaching. I learned a lot from it. But there are questions from you. But because we have kept Professor Baziak waiting, we are late. I think it's better if we discuss them in the panel.
That's fine. Yes, of course.
Final discussion. So now I am going to introduce Professor Baziak. Andrea was my supervisor in my fellowship time there in Princess Margaret Hospital. She was very kind to me and to my family also, and she is has been and is a great mentor to me. Thank you, Professor Baziak, for accepting to participate and lecture for us. Please go ahead.
Thank you very much. It's a pleasure to be here, and thank you to my colleagues and others on this webinar for very interesting talks. It was a pleasure to learn and hear about some exciting new information. You can hear me okay? I presume you can hear me okay. Are you going to be showing my slides, or shall I share my screen?
whatever you prefer. If
You can go ahead. It seems to be working well on your side, so you go ahead and show my slides. I wanted to tell everyone that Behmen was one of our most productive fellows, as those who know him are not going to be surprised. He was excellent clinically, very dedicated to the program that he was in, and very productive from a research perspective. So a very wonderful balance of clinical expertise and desire to improve knowledge and to contribute to knowledge. And obviously the collaboration and the leadership continues over the years. So it's absolutely a pleasure. So I'm going to talk, I hope briefly, about stereotactic radiation in lung and in oligometastatic cancer. Go ahead. You can just carry on. Thank you. I have no commercial interests, and acknowledgement to my next slide to my colleagues in the program, and as well to Dr. Barry, one of our colleagues who is one of the contributors to the oligometastatic program for some of the slides. Next slide, please. So I will talk about SBRT for early stage lung cancer and talk a little bit about the central tumor study that I was the PI on, and then speak a bit about SBRT for lung metastasis and other sites of oligometastatic disease. Next slide, please. Stereotactic radiation for early stage, these are my take-home messages. SBRT, especially in the lung, is safe and well tolerated, and for countries and centers that haven't yet started their SBRT program, I think lung is probably a good place to start. Lung and brain are perhaps two areas where there's clearly a lot of advantage to patients and relatively good, strong evidence and guidelines. I'm not going to talk about brain at all today. Careful selection of SBRT doses, it really depends on what organ at risk you're close to. And for lymph nodes, adrenal gland, bone, and central lung tumors, that is particularly critical. Goals in oligometastatic disease, everybody talks about survival, cure. Can we cure these patients? But I do think that local control, prolongation of progression-free survival, and improvement in quality of life of these patients are just as important goals as cure, especially since we can achieve these goals in many more patients than we can actually cure. And finally, combination of SBRT and immunotherapy appears very promising. Next slide, please. These are, two patients with early stage lung cancer, and obviously the one with a peripheral lesion is very straightforward to treat with high ablative doses for cure. The other one is a little bit closer to the airway and still can be treated with SBRT, but you just have to be a little bit careful about what dose fractionation to utilize. Next slide, please. It is the latter group of patients that was the subject of this study, RTOG, energy oncology, phase 1/2 seamless design study that I was invited to be the lead on, and that we published in a Journal of Clinical Oncology in 2019. Next slide, please. In that study, we started off with 10 gray given every second day for 5 fractions. As you may know, in US, for SBRT to be recognized as stereotactic ablative radiation, it has to be 5 fractions or less. So we were looking at what dose is safe and effective in patients with central tumors, lung cancer, medically inoperable early stage. So we started off with 10 gray, and we had a dose escalation up to next level, and depending on the toxicity, and we were able to dose escalate, and in the top 2 fractionations, we had quite a lot of patients. So this was a phase 1/2 study that at the same time determines the tolerated dose, as well as has enough patients to actually see the effectiveness without having to stop. So it's not the traditional 3+3, waiting to see whether you have toxicity or not before you can escalate. Next slide. In that study, we predetermined what was going to be a definition of tolerated dose. The patients were, as you would expect, 65% had T1 tumors, the rest were T2, and good performance status. For the most part, elderly, and every single patient had to be seen by a thoracic surgeon and declared not surgically suitable for surgery. I do want to emphasize that although all tumors were central in the RTOG definition of within 2 centimeters of airway or mediastinal pleura, so we didn't include tumors that were close to the heart or the vessels because of concerns about toxicity to the heart or vessels, but tumors were still in different locations. So for any one tumor, there was usually only one organ that was at risk. And relatively few patients had, for example, esophagus at risk. And many had airway at risk, but it was sometimes smaller airways rather than the major airway. So you have to bear that in mind when you translate the results of a study to your own patient population. Next slide, please. So we had predefined dose-limiting toxicity as grade 3 or above toxicity within the chest that is possibly, probably, or definitely due to radiation within a year of SBRT. So that's very important because the conventional, toxicity within 3 months of treatment doesn't quite do it for stereotactic radiation. We are worried more about the late toxicity than the acute toxicity. And these were the toxicities we saw. We did have 2 grade 5 toxicities, interestingly, at the lower levels. And then at the higher levels, we did not have any grade 4 or 5 toxicity. We had 2 grade 3 toxicities. But overall, taking it into fact the Bayesian logistic model that calculated what is the actual risk, we came up to a risk of around 7%, even at the highest level used. Next slide, please. So we did look at worst adverse events even beyond 1 year, and there were a couple of grade 5 toxicities at the higher levels beyond 12 months. And interestingly, all of the grade 5 events were hemoptysis, but not always related to the highest dose level. Next slide. The outcomes in terms of local control, overall survival, and progression-free survival are shown here. The blue is the 11.5 grade times 5 fractions, and the red is the 12 grade times 5 fractions. So they're really identical. The reviewers were pushing us to make a statement, is one dose level the recommended one, but we really couldn't make that dose statement because the study was not designed that way. The toxicity was similar. And again, I emphasize, you cannot say that this is necessarily safe for every single patient because the location of the tumors was variable, although they were all meeting the definition of fairly central. And I would caution you and others to be careful whether that would apply to a patient with this location of tumor. This would be considered ultracentral because the tumor itself is touching a very major bronchus as well as the vessel. It's relatively close to the esophagus as well. And we definitely did not have enough patients with this location to be able to say that the doses that we have used are still associated with only 7% risk of grade 3 or higher toxicity. Most of us think that probably the risk of toxicity in this location with those doses is higher. I'll now move on to stereotactic radiation for lung metastasis. As you know from surgical literature, there's definitely patients where resection of lung metastasis is associated with very long survival. And the results from colon cancer particularly are quite impressive because many of those series that show long-term disease-free survival after surgery for lung metastasis did not utilize chemotherapy. So it was really a local therapy for a metastatic lesion, pathologically proven to be a metastasis, and then patients do not get other metastatic disease. So, of course, the question is, can those patients be served just as well or maybe even better with a less invasive ablative treatment? Technical aspects are similar, in some ways actually even easier, because patients often have a better pulmonary reserve. They are not smokers, they haven't perhaps have fewer comorbidities, they often have better performance status. Lesions are frequently peripheral, but multiple lesions may present planning challenges, although now we have a lot more data to say that treating 2 or even 3 or perhaps even more lesions, as long as the volumes are small, is likely safe, even if treated at the same time. The challenges are more in terms of decision making. So, for example, somebody with previous locally advanced lung cancer has 2 lung nodules. Likely there are metastases, but there could be new lung cancer. And definitely if there is 1 lesion only, you don't know if it's a lung cancer or a metastatic lesion. With SBRT, it probably doesn't matter hugely, as long as the lesion is in a good location for SBRT. But for example, somebody who has a more hilar metastasis, this is starting to be a little bit more challenging. And I urge you to really consider, is this a lung nodule or a hilar lymph node? Because hilar lymph nodes, the SBRT dose needs to be much less. We tend to treat hilar lymph nodes. We didn't treat them for quite a while, and now with more information in the literature, we tend to give them something like 35 gray in 5 fractions. Really have to be more careful with those. And the problem with colorectal cancer is that there's a number of studies that suggest that dose control is not as good as with other cancers. So then the question is, what is that going to achieve? Probably if it's metastatic, eradication may not be essential to helping patients with prolonged progression-free survival, but we definitely don't want to cause toxicity. So it's a little bit challenging. So as I said, challenges are really more clinical than technical. Patient selection, what are the goals of therapy, what are the benefits and risks in comparison to other options. Another option, in this case, probably not surgery, but in many cases, surgery is a good option. So obviously, in this case, chemotherapy, systemic therapy is the main consideration. And then what level of evidence do we need to employ SBRT? Do we do trials, for example, for lung metastasis from any cancer, in which case we're really looking at the safety of a dose and the local response, or do we do trials of a metastasis to any organ from a specific cancer? I mean, ideally, you do trials of colon cancer metastasizing to lung, but then you really, it's going to be more challenging to mount a trial and accrue patients in a timely manner the more restricted you are. Next slide. Next slide is example. For example, in colorectal cancer, a very common cancer, these are 2 publications, one from PMH and the other from Odette Cancer Center, both parts of our university department, looking at, on one hand, liver metastasis from colorectal cancer, and on the other hand, extracranial SBRT for metastatic colorectal cancer. So for a common cancer, you can do it. For other cancers, it may be more challenging. Next slide, please. This area is fascinatingly important and relevant, particularly for oligometastatic cancers, 1 to 5 metastasis or 1 to 3, because of several recent phase 2 randomized studies that have shown very significant patient benefit. So this was a study by Daniel Gomez and colleagues from MD Anderson. It It was a randomization to local therapy, consolidative therapy for oligometastatic non-small cell lung cancer versus maintenance therapy or standard of care systemic therapy. And the study was closed early due to a very impressive prolongation of performance, progression-free survival if you give local consolidation. We are awaiting the overall survival results. Next slide. Sorry, this is the long-term results where there was also an overall survival benefit of local consolidative therapy with a very small number of patients. So impressive results. And around the same time, their colleagues just down the highway, I suppose, also in Texas at Southwestern, with other centers, did a phase 2 trial of consolidative radiation for oligometastatic non-small cell lung cancer. Again, study closed early due to results. Standard of care, systemic therapy plus minus SBRT to 1 to 5 metastases, including the primary if necessary, and again, a significant prolongation of progression-free survival. Very impressive results. Next slide. And our colleague David Palma, one of the leaders in oligometastatic SBRT from London, Ontario, was PI in this multicenter phase 2 study with 99 patients with a variety of primary tumors and oligometastatic disease up to 5 metastases, standard of care, plus minus stereotactic radiation, 1 to 2 randomization, and the top is overall survival. So there was a trend to improved overall survival if you give SABR, and below is progression-free survival, quite a difference if you give stereotactic radiation. Of note, 3 patients did have treatment-related mortalities, although at least in one of them it was complication of a complication of a complication of a complication. So kind of 4 steps away from immediate toxicity of SBRT. Our colleagues from ESTRO and ASTRO recently published a consensus statement how to define oligometastatic disease from a radiation oncology perspective, and I think it's a relevant paper for when you consider treating these patients in a more aggressive manner. So SBRT can be given to a variety of sites, and there's several things that need to be established in order to be able to do it safely. Motion management is critically important, particularly in sites like liver, adrenal, lung, of course. Next. And we want to reduce the ITV because there's a fair bit of motion of some of these lesions. Next slide. And these are examples. Next. It is very important to identify target. That's one reason I said lung is easy, because usually you see the target very clearly defined. Liver, for example, is quite a bit more challenging, and you need to be really an expert as the radiation oncology team in the various different modalities of how do you see that tumor clearly, how do you fuse the MRI or have MRI for simulation, and how do you identify your target. Next. Because without clear target identification, you cannot really proceed. Thirdly, you really need to know your normal anatomy. You really need to know all of these the various organs at risk and outline them and think about, are they moving? How accurate are you in outlining them? And what's going to happen on the treatment unit? Is the patient being immobilized well? Are you going to be able to reproduce it? Is it going to be the same as what you have planned? Next slide. I'm coming towards the end, and then the planning, right? Are you conformal? Do you do VMAT? Well, it's a steep dose gradient. So again, the importance of the target, the importance of organs at risk, and the importance of quality assurance. In our center, in our program, for years and years and years, we had another radiation oncologist review our targets for contours before it went to planning, because it's all about the contours. If the contours are correct, then the plan will be achieving your constraints. Next. There is a lot of current studies happening with systemic therapy, particularly with targeted therapy, for example, for EGFR and ALK and other mutation-driven non-small cell lung cancer. And there's a lot of trials on SBRT and immunotherapy combinations. A year ago, when I reviewed it for another talk, these were the types of questions that were being explored in these studies: timing, dose, efficacy, how does it deal with IO resistance, abscopal effect, etc., etc. Next slide. I'll give you just one tease in terms of, next slide, please, in terms of what it is that those studies, sorry, can we go to the next slide, please? So this is an example of a study presented at ASCO last year of, again, a very significant improvements in survival of TKI plus SBRT versus tyrosine kinase inhibitors alone with EGFR positive oligometastatic lung cancer. So how do, and then this is another study of pembrolizumab plus minus SBRT for stage 4 lung cancer. Now this is not oligometastatic, this is widely metastatic. And if you add SBRT, you improve progression-free survival. And this is not the only study that has shown that. So SBRT to one lesion may improve the response rates in that patient. So there's a lot of excitement on how to incorporate SBRT in polymetastatic stage 4 patients. Next. So how do we translate this into, sorry, this is another study from MD Anderson, also very exciting, looking at patients who had SBRT or standard moderate dose radiation, and it's the SBRT that seems to make a difference rather than just radiation. So more prolonged radiation, not as good. So how do we translate this innovation into practice? You need to have some technology, although interestingly, you don't necessarily need to have every single bell and whistle, but you do need teamwork, and you very much need the physicists, the therapists, and everybody to be a part of the process, because we're only as strong as our weakest link, and we definitely need to look at safety, quality, standardization, and processes in order to achieve what the literature says we can achieve. And the last two slides, one early on in our program back in 2008, we wrote this paper on some of the practical considerations arising from implementing lung SBRT at our center, and it talked about the teamwork and the processes, etc. And the next slide, very recently, some of my colleagues from our center and elsewhere wrote this paper, and very similar concepts, practical considerations of implementing SBRT for oligometastasis. So a lot of thinking about the process and the teamwork that is necessary for this to happen. So I will leave you with, again, my take-home messages. Last slide, please. On the importance, last slide, on the fact that this is safe and well tolerated, but you do have to think about OARs and careful selection of doses, and more exciting things to come in the future. Thank you.
Thank you, Andrea, for a very nice lecture, and I'm very thankful for the kind comments that you made about me at the beginning. So it was great. Thank you. I had Dr. Farhan also, I think, but for the audience, have questions from you. But I think because we are going to start the panel immediately after the script that we are going to show, so we can put our questions to you on the panel. Okay, so we are now in the Roxanwebinar company, and I'm very thankful to them for they have been very kind and very cooperative. And I'm thankful to Dr. Tabibi, the head of Roxanwebinar, and his colleagues, Ms. Kamere and Mr. Nasirian here, who is just beside me doing all the work. And they have been taking very good care of us with fruits, juices, tea, coffee, ice cream. So we have been being well fed during the webinar. So I'm very thankful to them. And this is a clip from Roxanwebinar. So now we are going to start the panel with all participants, and I ask Professor Beziak and Professor Chong to help me. Manage the panel, and also Dr. Farhan here will be helping me too. And Dr. Farhan, you had a question from Professor Beziak. Right?
Yes, thank you very much, Professor Beziak. I have a question. Have you ever compared SBRT for lung and liver metastasis to surgical resection, or are these two modalities equal regarding overall survival or disease-free survival?
I don't know. For lung metastasis, I don't know whether there have been a lot of direct comparison of SBRT and resection. The advantage of resection is twofold. The local control of that lesion is often very high, although you can definitely get a recurrence in the staple line, for example, and you get the pathology. And occasionally the pathology is a surprise, and you can have somebody who had a lung metastasis before, and now you resect a nodule, and the nodule is a primary lung cancer. So that's two advantages of surgery. With radiation, the local control is, fairly high. 90% is often what we quote. And again, for colon cancer, probably a little bit less. But it's non-invasive, and there are definitely cases that you couldn't do surgery. For example, on the liver, the liver is not my area, but there are areas within the liver that are not resectable, and where radiation is really the only option. So what we do is we discuss all of our cases with the surgeons together, and we discuss, what do you think, pros and cons of surgery for this lesion, pros and cons of SBRT, pros and cons of no treatment or systemic treatment. So I think it really needs a multidisciplinary discussion.
And another question, have you ever observed when you treat a metastatic lesion, have you observed other metastatic lesion to vanish regarding this abscopal effect? Have you seen this?
I don't think I have personally had a patient with an abscopal effect, unless they were on other therapy like immunotherapy, and even with immunotherapy, it's relatively rare. But I've seen all sorts of things. I've seen lesions spontaneously regress. I've had actually a number of patients in my practice where whether it took a long time to get the workup, and then you come to a planning CT and the lesion is considerably smaller, or a patient wasn't a candidate for aggressive treatment and the lesion regressed. So all sorts of things happen, but they are, I think, a bit rare. The excitement about some of the new studies is that there's perhaps ways that we can modulate the immune system with SBRT to increase the likelihood of abscopal effect. And some of the new studies with very low doses, high dose of SBRT to one lesion, but very, very low doses to other lesion or lesions may do a better job. So there's a lot of biology that we need to understand. And Dr. Milosevic's comments about understanding, the animal models and what's happening biologically is very important. Otherwise, we're just scratching the surface in terms of trying to see the clinical impact.
And there's a question from my colleague in my department to you. So you can see it in the question and answer part. So he is asking for lung mets, how many metastases can be treated by SBRT?
I don't know. Many of the trials, at least of oligometastatic disease, say no more than 3 lesions in one organ. But I don't know whether the future will confirm that as being the guidance or not. Right now, we're part of a randomized study of treating up to 10 metastatic lesions, but it's only on a trial. I would not do it. 10 lesions anywhere throughout the body. I would not do it in clinical practice. We very rarely would do more than 3. We're a bit conservative, right? Some centers will probably.
Okay, so Dr. Farhan, could you put the questions that have been asked to Mike Milosevic, please?
Mike, I believe the question for you was in the Q&A. Why is adjuvant plerixafor more effective than its concurrent use? I think Dr. Haddad wanted that question to be answered.
So we don't, thank you. I didn't hear that, or I didn't see it. So I don't think we quite know the answer to that, except that it is in effect, we believe, of upregulation of this pathway and in modulation of this migration of these immune cells into the tumor, which happens during and towards the end of treatment as opposed to earlier on during treatment. So you can give the drug either during treatment or afterwards, but afterwards is, it appears to be the time frame when you see the most benefit. And other studies have shown the same thing. There's a couple of other studies looking at glioblastoma, not in this exactly the same way that we did it by other groups, and they have shown that you can use plerixafor afterwards and you see this kind of protective effect on the normal tissues, and you also see this enhanced radiation treatment response. And I think, we don't know for sure, but I think it comes down to just the timing and the sequencing of those 2 treatments and, what radiation is doing to upregulate the pathway, which then causes the influx of these cells. And then those cells exert their effect on protection of the vasculature and other things.
And Professor Milosevic, I think you have mentioned that adjuvant plerixafor is more effective than concurrent use. Is it correct?
That's what our data would suggest, that you can give it afterwards and have at least the same effect, if not a better effect. And that's important because, when we talk about doing these things in a clinical trial setting, sometimes it's the toxicities and issues associated with high-dose curative radiation treatment are already challenging for our patients because we've pushed the profile as high as we possibly can. Adding this on, in an adjuvant factor in an adjuvant way for 3 or 4 weeks afterwards, we think will be better tolerated. There also is a theoretical advantage to doing it afterwards, and I kind of alluded to this earlier when you asked your previous question. One of the effects of these drugs is to mobilize bone marrow stem cells into circulation, right? That's the reason that this drug is approved by FDA for transplant purposes. And, I'm not too worried about that in the context of radiation alone. But when you're giving radiation with concurrent chemotherapy, concurrent cisplatin, if you're also mobilizing bone marrow precursors into the circulation at the same time as you're giving them cisplatin, there's a theoretical risk, at least, that you could actually ablate those bone marrow precursors to some extent and lead to bone marrow toxicity down the road. So I think in our setting, when we move this into the clinic, it will be in an adjuvant fashion after the radiation and concurrent chemotherapy is done. That was the reason we did those sequencing studies in the first place, just to look to see whether we could do it after radiation and chemotherapy and have the same biological effect, which we seem to.
Thank you very much. I have also a question from Professor Yarno. Professor Yarno, in ultra-hypofractionated schedule, do you also use supraclavicular portals or only tangential portals?
John, you're on mute. We can't hear you, John.
I do apologize that. Thank you so much, Andrea. Yes, thank you. For all the patients in the Fast Forward trial, the radiotherapy was only to the site of the primary disease, that is the whole breast after complete microscopic local resection, or the skin flaps on the chest wall after mastectomy. There is a sub-study which is in follow-up of several hundred patients who have had radiotherapy to the lymphatic pathways in addition, just with the 2 dose levels, 40 Gray and 26 Gray, with the primary endpoints arm swelling and a lot of other symptom scores by the patients and clinicians. But that will take another year or two before that report. Up to this time then, the UK standard is now 26 in 5 for patients who require just radiotherapy, local radiotherapy. And obviously the hope is that that might be extended to lymphatic radiotherapy in due course.
Do you have ever concern about brachial plexopathy after this high-dose radiation regimen?
Well, based on the standards so far, the experience with 2.7 Gray fractions, we know there's no concern there. Even assuming an alpha-beta ratio of 2 or 1.5, 40 Gray and 15 fractions, or the Canadian 42.5 fractions and 16 fractions, they're not going to be more intense on the nervous pathways, and we would expect that after 26 Gray and 5 fractions. As I said, assuming an alpha-beta ratio of 1.7, it's still within tolerance, 50 Gray. And depending if you place brachial plexus tolerance above 55 Gray, well, then there's a huge margin, and brachial plexus plexopathy doesn't really come in until after 60 Gray into Gray equivalents. So the safety margin is enormous. But clearly that all has to be established in clinical practice. Expectation and prediction is one thing. One has to verify that. But that at least is our perception in the UK.
So, as I mentioned earlier, this immune modulation response is my field of interest. Do you think this 5 fraction schedule will exert an immune modulation response which will contribute to this good results of your trial? Does it have a role in breast cancer, do you think? And Professor Milosevic, do you think in breast cancer this high dose per fraction will contribute, will exert radiation immunomodulation response and contribute to good results of hypofractionation?
Well, it's a jolly good question, and I think Dr. Milosevic is the ideal person to respond to that. I know my colleagues are very interested in the role of fraction size in actually activating CGAS sting pathways, and there's a lot of research in different centers around the world in that respect. But let Dr. Milosevic speak. He is our expert here.
No, and I thank you for that, but I'm not sure I'm going to be able to answer this one in any meaningful way. That's a tough one. And I think, there's a lot of excitement about all of this, and larger dose per fraction, within some range. As you go up too high, then there may be factors that, block activation of CGAS sting and all this other stuff as well. I don't know the answer. I think it's something that, is evolving as we speak. One of the challenges, and I'll just reiterate that, is that we're doing this all in patients, and we're not actually getting good biomarker studies to be able to evaluate what's happening. So it's all very empirical, which is not unusual to radiation oncology. A lot of radiation oncology over the decades has evolved in an empirical way. but it would be so nice to understand, in patients, ideally through biomarkers, and it's just really hard to get tissue biopsies in these patients, maybe liquid biopsies from patients when they're on these kinds of trials, so that we can assess, at least the circulating immune cell populations in response to radiation would be very interesting. But also having good preclinical models that are relevant, I think, because that's going to allow us to move back and forth and really advance the science. I kind of agree with, there's a lot of hype around abscopal effect and all of these other things. I'm not sure that it happens all that much. I agree with Dr. Baziak. It may happen occasionally under the right circumstances with a PD-L1 or some kind of immune modulating strategy on board. But I don't really think we know how to exploit that to its fullest right now. So that's a nice way of sidestepping the question, I think.
So there are a lot of questions to Professor Yarno. I think if you answered a few of them by writing, by typing. Is that
Yeah, I've typed in, yes, Behmn, I've typed in some answers. And I sent them, I think, to everybody, if they're interested. If there are any that you want me to speak to, then just tell me. But I don't want to spend time unnecessarily for your other speakers.
So you can see the questions in the Q&A. I can just down the page. So if there are a few questions to you, but I don't know which of them you answer. I asked the audience if you have a question from Professor Yarno who has not been answered by typing or his typing, please put them again there, and we will talk about it.
What I could say, if I'm not over talking, well, I know I am talking over you, I apologize, and you can interrupt back if I'm not spending the time well. But Dr. Milosevic emphasized the difficulty of actually investigating biological mechanisms in the clinical setting. And where fractionation is concerned, we've been looking at this, we've been thinking about this, haven't we, for 50 years in relation to the 4 Rs, and we're still not clear. I mean, the fast forward trial, for example, the tumor effect seems to be overperforming. In terms of late normal tissue damage, a schedule which is equivalent to 46 gray in 23 fractions is achieving an anti-tumor effect we'd expect to, say, 55, 60 gray. Now, that may be just a chance effect. And you could say, look, it's just a chance effect. These are very, very low local recurrence risks. Because if it's real, in a trial like Fast Forward, which is comparing 1 week with 3 weeks, we're not controlling for treatment time. And we've always assumed that with regards to tumor control, that repopulation isn't playing a role. But, several weeks after primary surgery or several months after chemotherapy, the stage of the cancer may be very different. We can't exclude a role of tumor time. In a similar way with the normal tissue effects, the alpha-beta ratio of 2 you can't deny the fact that the clinical data are real. They're very, very solid. What does an alpha-beta ratio of 2 assume? It assumes complete repair within 24 hours and no repopulation. Well, for a start, we know that endothelial cells have a very, very slow repair component with a third component, if you like, with a T1/2 of about 40 days. There could be say, 1% incomplete repair factor between daily fractions of 5.2 that actually, in a sense, nudge that alpha-beta estimate a little bit lower. Another factor is that you don't get moist desquamation with these schedules because the total dose reduction is so high. So you get no grade 3 desquamation, even in the heavy-breasted women. So you get no causative late effects. The late effects are the direct consequences of the early effect. And those causative late effects have high alpha-beta values, 10, 20 gray. And so if you don't get them, you may not have that. The alpha-beta value may be a truer reflection of fraction size sensitivity, and it's not, if you like, diluted by a component of consequential late effect. Now, those are speculations, and I guess they just heighten again Dr. Milosevic's point that, we know a lot more about the clinical responses than we know about the underlying biology, even decades after, the 4 Rs were first postulated by Ronald Withers. I mean, it's astonishing, but it's true.
I have a question for Dr. Baziak. So I know I don't remember the names, the brand names, but I know that there are monitoring systems with cameras and everything. I asked you last night for monitoring the patient position and keeping SPRT on the exact location. So is that required? I know that there are a few companies selling them. As I said, I don't remember the brand names. Is it really necessary to have them for SPRT?
I don't think.
Of course, we should have combi, of course.
I don't think it is necessary. We don't use it, we were involved in evaluating a system, but we don't use anything clinically. Positioning and precision is critically important for brain and for spine, but in other areas, regular immobilization is probably sufficient, and comfort of patients is quite important. So we don't use extra immobilization, and we definitely don't look at patient. It is possible that they're moving a little bit. The other advantage is we use VMAT, which means the delivery time is shorter, because initially when we used many beams, including non-coplanar beams, the delivery time was longer. So comfort and quick treatment are probably most important. The pioneer of SBRT in lung was Bob Timmerman in US, and he did it without 4D and without cone beam. So that was a bit brave, and we definitely rely on cone beam tremendously, and we wouldn't do it without cone beam and without respiratory motion assessment, but it has been done. We can't hear you, Behmon. I'm sorry, your microphone is on mute.
We will just have a very, very, because we are late on time, but we are very late in the panel time. So please just keep it very short. Please show the performance slides. It's about radiomics, and it maybe to some extent ties with Peter, Professor Chang's talk. So I have a question to Peter afterwards, after this.
Okay, I'm going to talk briefly on a new area of research called radiomics. As we know, as an introduction, organ-preserving approaches to cancer patient is not a new concept. It has been tested with successful results in breast cancer, prostate, head and neck, cervical, anal cancer, and recently in rectal cancer as a policy strategy named watch and wait policy. When you look to the effect of chemoradiation, you will find a subgroup of patients that will develop a complete clinical response. So the question arises here, why are we subjecting these patients to a mutilating surgery? And but some people may say that you cannot predict clinical responses, and patients may have residual disease despite having perceived as complete clinical response. So how can we predict response to chemoradiation? So accurate prediction of response remains an urgent need, but how do we identify this complete clinical response? Recently, there has been this area of research, radiomics. In radiomics, they derive features from baseline imaging studies such as computed tomography and MRI studies and provide information about response to neoadjuvant chemoradiation. So radiomics, as definition, is extracting more information from medical imaging using advanced feature analysis. A wide range of machine learning algorithms and also ensemble learning algorithms has been used to extract these features. Regarding this radiomics, Professor Haddad and his colleagues conducted a study for radiomics in our department. And next slide. The aim of the study was to investigate and validate performance of ensemble machine learning models based on MRI to predict response to chemoradiation in rectal cancer patients. 98 rectal cancer patients were entered into the study. All patients underwent MRI a week before neoadjuvant chemoradiation, and they found, according to features, as a clinician, I cannot explain what are these because these are machine learning and I am not aware of all these terminologies, for example, intensity, shape, and texture. But at the end, they found that machine learning methods can be used to predict neoadjuvant response to neoadjuvant chemoradiation in rectal cancer patients. So it's a new approach, and this radiomics is, I think, is 1 decade old. It's a new area of research, and I'm going to ask also audiences and our esteemed speakers, do you have any information and data regarding radiomics to share with us and with our audiences? Have you any study or any data? Thank you very much.
Can you hear me okay?
Yeah.
I think this is a really exciting area as well. We have quite a large radiomics program at UHN and in Princess Margaret, really focusing on head and neck cancer. That's been the area of greatest interest right now, just because we have lots of annotated data sets with strong linkages to outcomes. So we know, we can look at all those data sets, and the team can, look at extract radiomics features and link it to outcome. And, one of the really interesting things with radiomics, going back to some of the initial studies, the AERTS study that was reported maybe 5 years ago in lung cancer and other cancer types, really kind of set the stage for looking at radiomics and radiation treated patients. We had a graduate student here who was working in that space as well, and she tried to reproduce those results, and she was able to reproduce them, but it turned out, actually, and she's published these data in the literature, it turned out that most of the correlation between radiomics features and outcome in head and neck cancer that was in that original paper was explained by a relationship with tumor volume. So most of the features that you just showed us, texture and shape and all these other things, actually end up being strongly correlated with tumor volume in many of these data sets. So I think we just need to, my takeaway message from all the work that our student Matea did, and you can download those papers, is that radiomics has promise. It's actually really exciting, but there need to be strong clinical input into interpretation of the radiomic signatures that are being derived. Because a clinician would tell, people that volume, we all know that volume is bad, large tumors do worse. And if all we're doing is deriving imaging surrogates for volume, that doesn't make much sense. So I'm cautiously optimistic at this point. I think there's really likely to be something that comes of this, but we just need to be very careful about how we interpret the data. So in fact, Matea Welsh, there's a number of these papers coming out right now about safeguards in the use of radiomics and how we can do radiomics studies safely without overinterpreting the data or misinterpreting the data. Matea published this in the Green Journal maybe a year or two ago, her work. I think all of that needs to factor into these kinds of analyses.
Yeah, I would tend to agree with Mike in that it shows promise. I don't think it's ready for prime time. I really feel that this is really at an exploratory level at the present time. Any data that is produced really needs to be correlated in a prospective fashion. in order to actually make determination of what the promise in prediction of outcomes and clinical responses. Likely, in an ideal world, one would somehow be able to correlate the radiomics with tissue, because that's probably the gold standard in terms of, at least in terms of response assessment. And sort of the so-called radiogenomics approach. But all of these are quite exciting areas of investigation to be performed in the future.
Had to leave, and so I ask you, what is the level of PSMA therapy used in Canada? Because I know that it was more widespread in Europe and North America. But how is the situation with PSMA therapy now in Canada?
So PSMA PET scans in Canada are still very well. It's still considered an experimental investigation. So right now we have PET clinical registry study, at least in Ontario, in Toronto and in Ontario. We have not yet moved to therapeutic use of PSMA. It's really just been more of a it's really been more of a diagnostic procedure that we have available, but not no therapy as yet. Lutetium is in Canada, but certainly not in the prostate environment yet. So
there is a question from Dr. Malita, a good colleague, to Professor Yarmold, but because we're very late in time, please answer very briefly. What is the relationship between receptors in breast cancer and alpha-beta ratio? You're mute. Unmute, please.
Yeah. Thank you very much.
No, you have been muted. Professor Yarmold, unmute again, please.
I'm sorry that I'm so incompetent there. Now, I've written a text, a response to that. It's a jolly good question. And of course, we have looked at it. We can't resist doing that. But you see, the number of events is not very high. Even a few hundred events you see over in all the UK trials. And even if you look at the other trials, 14,000 patients, when you look into individual publications, there isn't an obvious interaction with receptor grade. And I must say that in the UK, that we don't discriminate on the basis of receptors. Our guidelines would say, look, regardless of receptor status, hypofractionation is perfectly satisfactory. And our overall recurrence rates could be consistent with that. I mean, for example, with our triple negative patients, I mean, the recurrences are really uncommon. We don't attribute that to hypofractionation. We just say, look, it's not a problem with hypofractionation. And that's where the matter rests. And I think that when we're looking at the biology of fraction size sensitivity, our focus would be on how double-strand breaks are processed. It would be to do with chromosome translocation mechanisms and processing and repair mechanisms. And there's not necessarily a direct. They could be links with receptor status. But they're not. We don't think they're important enough to really invest a lot of time in. If there was a big clinical problem, then we'd be more interested. I hope that helps.
Question. I don't know who in the lecturers would be happy to answer this question. Maybe both Peter, Mike Milosevic, and John. So it's we have a lot of trouble distinguishing post-radiation fibrosis from recurrent or relapsing tumor. Is there anything radiomics can do about it? So please answer very brief. Who is it? Mike, would you like to answer that? Unmute, please. Unmute.
Okay. I think people are looking at that question. It's not a focus of activity that we have here, but I think people are. I just, as Peter said, I'm not sure it's quite ready for prime time yet. It's all data that are emerging, and it may be that this is something that's quite useful, but I don't think we can rely on that at the present time. And then, you know, it comes down to, you know, what's the gold standard as well when you're trying to distinguish fibrosis from normal tissue or from tumor on a CT scan. Often we don't have biopsies to actually document what's what, so it gets a bit complicated. But these are all areas that are possible, I think, with radiomics. The challenge with radiomics is that you can basically get anything you want out of it, depending on the assumptions that you make and whatnot. That's maybe kind of a pessimistic view of it, but we have to be very careful, I guess, would be my message.
John, what do you think? Do you have anything to add to this?
Sorry, were you asking me, Behmon?
Yes, if you have anything to any comment.
No, I've referred to Peter. I mean, I'm not an omics person. I know that's a rather weak response to make, but there are so much better people on the panel that should be answering that.
Okay. All right. I think there is can I see the questions, please? There are no more questions, and we have long past the time of the panel. So we still have we had about more than 100 participants now, and there are like 54 of them still with us. And so and I thank Mike, Peter, John, Rebecca, Wong, Professor Wong, Professor Basiak, Professor Dehu, and I missed everybody, Professor Dr. Mohammad Jafari, and everybody here that helped us with this panel, with this webinar, sorry. And I thank the audience for being with us and asking interesting questions. Thank you again, and thanks to to the Darian Selamat company, representative of Ipsen in Iran, and to Roxanwebinar company, and to all of you again. Any comments from the lecturers or not?
I'm sure. To thank you, Behmon, very much for organising this and inviting us all, and thank you to my fellow panelists for their excellent talks. Thank you very much indeed, and thank you to the audience.
Mike, before you go, can I ask you about that idea that I had a webinar for quality control? Is that, will you be happy to participate, or any other people from here? So I unmute you. So I had a suggestion about the webinar for quality control in radiotherapy, because that's a very important issue, and now it's being looked at very carefully in Iran and being done, of course. So would you be happy to participate in that webinar if we can arrange one in near future?
Yeah, I certainly would be, and that would be fine with me. Yes, thanks, Behmon.
Okay.
Thank you.
Anything?
I don't think personally I've got anything to contribute to that. I mean, I've been out of the clinic now for many years, but there'd be other people connected with the trial. In other words, the next generation of trialists who are running the quality control program. I'm sure they have something to offer if you needed them. So you and I can just remain in touch if that's helpful. But clearly, you've got a lot of expertise on the panel already, even without that.
Okay, thank you again. Thanks, Dr. Farhan, for helping. And hereby I say goodbye to all the panelists and the audience. Thanks.
Have a good day. Good evening. Bye. Bye.
من از انجمن رادیولوژی ایران که اجازه دادن و ما مشارکت کردن هم خیلی سپاسگزارم. حالا توی گروه‌های چون خیلی دوستان دیگه رفتن از جلسه بیرون، توی گروه‌های اونکولوژی کارونکولوژی هم تحقیقاتمو خواهم کرد. خیلی سپاسگزارم از انجمن پژوهشکده سرطان، انجمن رادیولوژی ایران که اسم کاملش رو بگم، و همه کسای خانم محمدی دستی، خانم محمدی خیلی کمک می‌کردن، کارشناس مرکزمون، و هر حال ممنون و متشکرم.